All right. Assalamu alaikum wa rahmatullahi wa barakatuh. Once again, we meet, but this time we meet online for the first revision session at the endocrine division of the internal medicine department, Faculty of Medicine, Alexandria University. For those of you who don't know me, I am Mona Aboul-Seoud. I am a professor at the endocrine division of the internal medicine department, Faculty of Medicine, Alexandria University. Of course, I have put on my video camera so that you can see me and so that you know who I am, if in case you don't know me. Of course, I wish that each and every one of you could put on their video cameras as well so that I can see you face to face, although I see you in the weekly scientific meetings, but unfortunately, I don't know the names of all of you. I know only a few, unfortunately. But I suggest if we do that, I think the bandwidth of the internet will not hold and the meeting will crash. So I will not ask you. Don't be afraid. I will not ask you to put on your video cameras. And then I would like to put some ground rules by which we should abide all through the meeting. Please put your microphones off or keep them mute all the time to lessen the background noises and the echoes. Whoever wants to make a comment or who wants to ask a question or who wants to suggest something, just raise your hand and unmute yourself to talk. But for heaven's sake, don't talk all of you at the same time. Otherwise, I won't be able to understand who is saying what, okay? And as I mentioned earlier, we are all hopefully sitting comfortably at home. So you are allowed to eat and drink during the session. Okay, unlike the physical presence at the department. And of course, whenever you feel tired, just let me know so that I can give you a break. All of us, we are human beings, including myself. We tend to get tired as well. All right. So just let me know. Okay. This is all I wanted to, yes, and the last thing I wanted to tell you is that by the end of today's revision session, I'm going to put a link for a survey in the chat of Microsoft Teams so that I can get your feedback. I want to know from you whether the session was beneficial or not, okay? So please, depending on the number of students who remain till the very end, this is the number of responses I expect to find. So please, yani, participate in this survey, because this way you are going to help me to improve my online teaching, okay? I would be very grateful if you help me to in the evaluation of my online session today, okay? Anything else I wanted to tell you? That's it, I think. So now we are at 11. We are 11 students. I don't know how many you are in total. Can somebody tell me? Dr. Nadine or Dr. Selma, or do you know how many you are? How many master degree students are enrolled? I have like 20.
I'm not sure, doctor, but they're like 20 or more, yeah. So
Yes,
sure.
I think you are 26. I have 26 names in the Google contact list. 26 names, but now we are only 11. No, never mind. Like we say in Arabic, الغايب ملوش نايب. Huh? Those who are missing, they don't get the benefit. Anyway, let me start sharing my slides. As I mentioned, today is the first revision session. Usually I hold the revision sessions towards the end of the semester, but I noticed that the students prefer that they are held earlier. This way they can benefit more. All right. Can you see my slides now? Are my slides visible? Are my slides visible?
All right, doctor.
Type. Are they in slideshow or are they small? Huh?
Slideshow.
Good. Are they moving or are they fixed?
Moving.
Great. Okay. So today is the first revision session, inshallah, and these are the intended learning outcomes. By the end of today's session, you will be able to understand the anatomy and physiology of the hypothalamic pituitary axis. You're going to be able to list the symptoms and signs of hypopituitarism. You're going to be able to list the signs and symptoms of acromegaly, and you're going to understand the various imaging modalities in hypothalamic and pituitary diseases. I like to stress always on the symptoms and signs because maybe you don't see enough patients in the ward. And I like also to stress the imaging modalities because I from my experience, Yani, along the years, I find that I detect and I find that most of the students have problems reading the different imaging modalities. Okay? So let's start very basic with the anatomy of the pituitary gland. This picture you know already from your anatomy textbooks, okay? And there is no problem if we don't remember. We are all humans, including myself, and we tend to forget. But the problem is when we know that we forget something, we have forgotten something, but we don't go and revise it, okay? So this is the skull open in this, the yellow structure is the skull, all right? And inside it, it's open along the sagittal suture, as you can see. And this is the brain, the frontal lobe, the parietal lobe, the occipital lobe. This is the cerebellum and the brainstem, okay? And this is the corpus callosum connecting both hemispheres together. This is pure anatomy. This area, if you enlarge it, this is the area of the pituitary and the pituitary gland and the stalk and the optic chiasma here, like this, okay? So from your anatomy, you know that the pituitary gland lies inside, at the base of the skull, inside a bony cavity in the sphenoidal bone called sella turcica, this one, okay? It's very small in size, not exceeding 1 centimeter in all dimensions. And mind you, its size doubles during pregnancy. This is important, of utmost importance. Why? Because it can explain something that occurs after postpartum hemorrhage, namely Sheehan's syndrome. This is postpartum pituitary necrosis. If the pregnant lady has any cause that is responsible for her developing postpartum hemorrhage, and she is delivering at home, for instance, she develops postpartum hemorrhage and is not treated promptly, and she is shocked, okay, then she risks developing Sheehan syndrome due to postpartum pituitary necrosis, okay, from the shock that she developed because of the postpartum hemorrhage. And of course, the pituitary gland is very small. It weighs only 500 to 900 milligrams, not even 1 gram, all right? But in spite of that, it is called the maestro of all endocrine glands, all right? The master gland. So this is the picture that I showed you earlier in the anatomy textbook. The same exact picture we can see in a living human being, okay? This is, of course, the MRI, the magnetic resonance imaging picture of this same structure here. As we mentioned yesterday in the scientific meeting, you have to, whenever you see an imaging procedure, you have to mention whether it is a plain X-ray and the view, whether it is an AP view, lateral view, oblique view, whether it is a CT of whatever organ, the adrenal, whatever, and the cut, whether it is an axial view or a sagittal view or a coronal view. And of course, when you have a magnetic resonance imaging, you have also to mention the cut, like here, it is a sagittal view, but you have also to mention whether it is a T1 weighted image or a T2 weighted image, okay? How can we know that? By looking at the CSF. Where is the CSF? I will tell you in a minute. The structures of the human body appear in different shades of gray up to from white to black, okay? So this is the skull, all right? And the scalp and the subcutaneous tissue, okay? And the soft tissue appears in shades, different shades of gray. So here is the frontal lobe, this part here. This is the parietal lobe, this part here. This is the occipital lobe, this part. This is the cerebellum, this part, okay? And this is the corpus callosum. Same anatomy as if you are looking inside an anatomy book, but in a living human being. And what appears black is, like I mentioned yesterday, air. So this is the air in the frontal air sinus, air in the sphenoidal air sinus, air in the oropharynx, and air in the trachea. All right. And CSF also appears black. So this is the fourth ventricle. Okay. CSF appears black. And here is the CSF around the spinal cord. Okay. And air, برضو, air, this is air in the trachea. Okay. Let me show you the anatomy. This is the nose, the nasal septum, and this is the upper lip, the lower lip, the hard palate, the tongue, the epiglottis. Okay. And here, if you look closely, is the pituitary gland. In sagittal view, it appears, you can see the anterior pituitary, it appears more gray in color. And you have the posterior pituitary without using any contrast. It appears as a bright spot. You see, it appears white in color. Why? Because of its high content of antidiuretic hormone. And here is the pituitary stalk, and this is the hypothalamus, right? Through which secretes the different releasing and inhibiting hormones that trickle down the pituitary stalk to reach the anterior pituitary gland. And here is the optic chiasma. And of course, if you look closely, there is an ample space between the optic chiasma and the anterior pituitary gland. So far, any problems? Am I going too fast? Am I going too fast? Or am I going too slow? You just tell me. Can you still hear me? Huh? Answer me, please. Type, okay, fine. All right. So like we have a sagittal section, this one. This was the sagittal MRI of the pituitary gland, T1 weighted image. We have a coronal view. A coronal view is cut along the coronal suture like that, if you can see my picture, okay? So let's look at the anatomy. Still, we are in T1 weighted images, okay? Type. So air appears black. This is air in the oropharynx. And this is air in the sphenoidal sinus, okay? And CSF and flowing arterial blood appear black, okay? So like I mentioned yesterday, this is the internal carotid artery on the left side, and this is the internal carotid artery on the right side, okay? And this is the lateral ventricle containing CSF, okay? And yesterday I told you in the scientific meeting, why does the single internal carotid artery appear double on coronal cut? Who can tell me? Just to make sure that you understood what I said yesterday. Huh? Who can tell me? Do you remember what I said about that yesterday? Come on, don't do like the undergraduate students. They take forever to answer a simple question. If you don't know, just tell me, I don't know. There is nothing wrong in admitting that we don't know. من قال لا يعلم لا أعلم فقد أفتى. Right? Huh? Who can tell me? Shall I pick a name? Shall I pick a name? Yeah, it's better that you volunteer. Yeah. Let me see. Let me see. Who can tell me? Shall I pick out a name?
Carotid siphon, يا.
Yes, exactly, because of the carotid siphon. All right, thank you very much. The carotid siphon. If you remember your anatomy, the internal carotid artery, which is single on each side, it makes like a C-shaped turn. And when you cut it coronally like that, it appears like two apertures, okay? So let's revise. This is the, let me put the laser pointer on. This is the pituitary gland here. You notice that the normal pituitary gland has a flat or concave upper border. This is important because later on when I will show you the imaging in pituitary adenomas, microadenomas, we will see the difference. So always note the upper border of the normal pituitary appears either flat or concave, like that, not convex. Okay, and the pituitary stalk is central. It's not deviated to the right, and it's not deviated to the left. Okay, on either side of the pituitary gland are the cavernous sinuses. The contents of the cavernous sinuses are the internal carotid artery, okay, as well as the cranial nerves, some of the cranial nerves. Number 3, the oculomotor. Number 4, the trochlear. The upper 2 divisions of the trigeminal nerve, the ophthalmic division and the maxillary division, as well as cranial nerve number 6, or the abducent nerve, okay? And this is the optic chiasma. Again, you notice there is ample distance between the pituitary gland and the optic chiasma. So far, any problems? Any problems? This is the normal anatomy, okay? The normal anatomy. This is a prerequisite so that we can understand what is abnormal in the pituitary imaging, okay? So let's continue. Now I'm going to quickly revise hypopituitarism, okay? The consequences of hypopituitarism, as you all know, are the deficiency of multiple anterior pituitary hormone production, like growth hormone, for example. Growth hormone deficiency in children produces short stature. In adults, until very recently, it was said to have no effect, but in a minute I will mention that it can cause problems in adults as well. As regards the gonadotrophin deficiency, FSH and LH, whenever they decline, their level declines, this will cause infertility in the male with hypogonadism, secondary hypogonadism, and reduced sperm count. And it can cause also secondary hypogonadism in females with menstrual irregularities up to complete amenorrhea, right? And whenever TSH deficiency occurs, this will lead to secondary hypothyroidism, okay? And whenever ACTH deficiency occurs, this will cause secondary hypoadrenalism with loss of pigmentation and hypoadrenalism, okay? And of course, ADH deficiency can cause diabetes insipidus, but many of the textbooks, they don't consider diabetes insipidus as part of panhypopituitarism. Panhypopituitarism is exclusive for decreased anterior pituitary hormone production, okay? Except, of course, in craniopharyngioma, for example, craniopharyngioma can cause diabetes insipidus in addition to panhypopituitarism. Okay? So far, any problems? Any problems till now? Am I going too fast? This is, I assume this is, yani, you know all that, right? This is, yani, common knowledge, hopefully. So regarding the clinical features of hypopituitarism, we have some common symptoms and signs in both genders, like due to TSH deficiency, which will cause mild to moderate secondary hypothyroidism. And it will also cause secondary hypocorticism due to ACTH deficiency, which will lead to weakness, postural hypotension, pallor, and hypoglycemia. But it depends. There are some clinical features that differ according to gender. For example, women can present with amenorrhea, absent or cessation of menstruation, which may be primary or secondary. And do you know the difference between primary and secondary amenorrhea? Can somebody tell me the difference, please? Who can tell me? Huh? Who can tell me? Is there a difference between primary and secondary amenorrhea? Shall I pick a name? Yani, don't force me to pick somebody. Good, now we are at 14. Let me pick a name. Dr. Let me see. Dr. Riwa Talat. Can you please tell me the difference between primary and secondary amenorrhea? Sorry?
Yes, primary amenorrhea. She never had a menstruation. or a late onset يعني ما جالهاش أصلا.
Yes, delayed puberty يعني كأن it's due to delayed puberty. Very good, yes.
لكن secondary إن هو بيكون already a normal female بnormal puberty menstruation بعد كده بيحصل stoppage ليها يعني.
Okay, cessation of menstruation later on in life. طب what is the most important cause for secondary amenorrhea that you need to exclude?
Pregnancy.
Exactly, very good, Dr. Rewa. Where do you work, Dr. Rewa? Where do you work? Very good, excellent. Okay, can you still see my slides? I sincerely hope you can. Okay, in women, they can complain also of infertility. A married lady who has been married for like 5 years with regular sexual intercourse, but she cannot get pregnant. So this is infertility. Vaginal atrophy and dyspareunia. Dyspareunia means painful sexual intercourse. Okay. These complaints usually such ladies, they usually present to the obstetrician or the gynecologist. Okay. Breast atrophy. This is an important complaint as well. Loss of axillary and pubic hair, like what occurs in Sheehan's syndrome. Okay. In men, they complain of loss of libido or poor sexual desire, or loss of sexual desire, or impotence, failure of erection, which leads also to infertility. Okay. And as a sign, you can notice when you examine a male patient with hypopituitarism, they can have soft atrophic testes with loss of secondary sexual characters as well. They don't have beard or mustache or even breast hair or body hair. Okay, so this is like I'm going to show you later on. This is what we call alabaster skin. I'm going to show you a picture of such a patient. Okay, so far, any problems? Any problems still here? Right. So the clinical features of hypopituitarism, which include the symptoms or the complaints of the patient and the signs, these are what you as physicians detect upon examining the patient. They depend on the extent of hypothalamic and or pituitary deficiencies. All right. So secondary hypothyroidism and adrenal failure, both of them lead to tiredness and general malaise. These are the symptoms. And secondary hypothyroidism, in addition, causes weight gain, slowness of thought and action, dry skin, and cold intolerance. Okay, so far, any problems? Nothing new. I assume there is nothing new. You know that already. Okay, now, in hypopituitarism, don't expect there to be hypoprolactinemia, except in Sheehan syndrome. Okay, but all the other causes of hypopituitarism, like for instance, pituitary tumors, any like craniopharyngioma, for example, it's all also, although it doesn't, craniopharyngioma, although it doesn't arise from the pituitary gland, it arises from Rathke's pouch, like I'm going to discuss later on, but it can extend downward to involve the pituitary gland and the pituitary stalk. Okay, so in these conditions, there will be hyperprolactinemia, okay, which may cause galactorrhea in ladies and secondary hypogonadism. Okay, so why? Who can tell me why does hyperprolactinemia occur in cases of macroadenomas, pituitary macroadenomas that extend upwards, causing stalk effect? Who can tell me? This is very important.
علشان يا دكتور الدوبامين بيبقى ليه inhibitory effect على البرولاكتين وهو بيبقى موجود في الستوك، فلما بيبقى الادينوما لما بتضغط على الستوك الدوبامين inhibitory effect بتاعه بيقل فبيزيد البرولاكتين.
Excellent, Dr. Sama. Can you please repeat in English? Because Dr. Aboul-Seoud didn't understand what you said.
Okay, due to the loss of the inhibitory effect of the dopamine, which is already stored in the pituitary stalk.
No, it's not stored in the pituitary stalk. Let me explain to you. The dopamine actually comes down from the hypothalamus through the pituitary stalk to the anterior pituitary gland. So dopamine has a constant inhibitory tone on prolactin secretion from the anterior pituitary. So if the stalk is cut for any reason, for example, due to a tumor extending upwards or cutting of the pituitary stalk, due to surgery, trauma, what we call stroke effect, okay? This will interrupt the constant inhibitory dopaminergic tone on prolactin secretion. So it will be released. So there will be hyperprolactinemia. Okay, is that what you meant, Dr. Sama?
Yes, doctor, yes.
Okay, thank you very much. Thank you. Is it clear? Any problems? Any problems with that? Are there any problems grasping this concept? This is very important. Okay, so back to my slides. I hope you can still see them. Okay, so in cases of hypopituitarism, we can, except in Sheehan syndrome, we will find hyperprolactinemia. Okay? In case of growth hormone deficiency, as I mentioned earlier, in children, it causes growth failure or short stature. But in some adults, it can cause impaired well-being as well. Because it was noticed in studies, epidemiological studies all over the world, they found that adult patients with pan-hypopituitarism who have been replaced with all the pituitary hormones except growth hormone, they still feel sick. They have impaired well-being. So they started looking why, what was the cause behind that, and they discovered it was due to growth hormone deficiency. So now is the big debate: shall we replace growth hormone in adults? Yes or no? Okay, there you can read about that. It's not the point of discussion today. And the weight, regarding the weight, it may increase due to secondary hypothyroidism, or it may decrease like in severe combined deficiency, what we call pituitary cachexia. I will show you some pictures of some patients in a while. Okay, and long-standing pan-hypopituitarism gives the classic picture of pallor with hairlessness, what we call alabaster skin. So this is galactorrhea I was telling you about. The patient comes complaining, obviously a female patient comes complaining that there is milk coming out of her nipples. The first question you need to ask her is what? Are you lactating? No, because by definition, galactorrhea means milk secretion from a non-lactating breast. Okay, so the second question that I want to ask you, can a male patient develop galactorrhea? Yes or no? Who tells me yes, tell me why. Who tells me no, tell me why. Do you understand my question? Can galactorrhea occur in male patients as well? Yes or no? Who would like to answer?
Yes, in some cases of gynecomastia.
Not really, because why not, Dr. Sama? Gynecomastia is not necessarily associated with galactorrhea. This is one thing. But why? Although it's written in textbooks, many textbooks write that galactorrhea can occur in male patients, but actually in clinical practice, I have never seen a male patient with galactorrhea. Why not? Why not? Think about it. In order for prolactin to act, what does it act on? It needs primed breast acini, like those present in women or girls, after puberty. Okay? But what about men? Even those who have gynecomastia, do they have adequately formed breast tissue or breast acini? No. So even if prolactin is high, how will it produce milk secretion? Doesn't make sense, right? You agree with me? Does it make sense to you? Huh?
Yes, doctor.
So in spite that it is written in many textbooks that galactorrhea can occur in men, in actual clinical practice, I have never seen galactorrhea in a male patient, right? But so back to galactorrhea, which by definition means milk secretion from a non-lactating breast, okay? Sometimes you ask the female patient, is there any milk coming out of your nipples? She will tell you no, okay? But you as a physician, you have to make sure that she doesn't have galactorrhea. How do you do that? When you examine the patient, you squeeze the nipples. If there is any secretion coming out of the nipple, this is considered galactorrhea. But we call it expressible galactorrhea, okay? So this is a milder form of galactorrhea, all right? The galactorrhea that is complained of is usually spontaneous. The lady will tell you, my bra is full of milk or is soiled with milk, okay? Or I can see milk coming out from my nipples. This is galactorrhea. So far, any problems? All right. Remember the pituitary cachexia I was telling you about? These are several patients. This is, you see, this is a young lady. She appears like skin over bone, like as if she has malignancy, but she doesn't have malignancy. This is severe combined pituitary, anterior pituitary deficiency, what we call pituitary cachexia. And here are pictures of patients before developing the pituitary cachexia. She had well-developed breasts, buttocks, the subcutaneous fat, but here after she developed pituitary cachexia, you see breast atrophy, and she's like skin over bone, like a skeleton, like people with malnutrition. Another patient with pituitary cachexia, you see the breasts are still there, but if you ask the patient, she will tell you there is breast atrophy, and you see the pelvic bone even appears as if she is a skeleton covered by skin. And this is the same patient. This is the patient before having developed pituitary cachexia. You see she had well-developed breasts, and she had a good pelvis with a good subcutaneous fat distributed all over her body. But after she developed pituitary cachexia, you see skin over bone with severe breast atrophy. Is it clear to you? This is what is meant by pituitary cachexia. Okay? Now, coming to the alabaster skin. This is a male patient with pan-hypopituitarism, right? He is an adult male. He complains of feeling cold all the time. He is lethargic. He feels dizzy on standing, and he is weak, and he has constipation. All these symptoms are due to secondary hypothyroidism and secondary hypocorticism, particularly feeling dizzy on standing due to postural hypotension. Coming to the signs, you see, he has pallor, not only in the face or in the mucous membranes, but all over the body. You see, the skin all over the body appears very pale yellow in color. And it's hairless. The skin of this adult male is hairless. He doesn't have pubic hair. He doesn't have axillary hair. He doesn't have a beard or mustache. He doesn't have any chest hair. He doesn't have any hair on the arms or legs or on the abdomen, like normal men. Okay? So this is what we call alabaster skin. And in a minute, I will show you what alabaster is. If you look closely, he has wrinkling of the skin around the eyes and mouth. But here, of course, the eyes are covered for privacy. But if you look closely around the mouth, he appears as if he's a young, old man. This gentleman is in his 30s, but he appears to be old due to the wrinkles around the mouth and eyes. He has loss of secondary sexual characters, like in absent pubic hair, like I mentioned, and loss of pubic hair. And he has loss of beard and mustache hair as well. And this is alabaster. Have you seen this? Those of you, the Egyptians, would of course know what alabaster is, because our ancient ancestors, the ancient Egyptians, they used to use this precious stone, alabaster. It's not a precious stone, it's stone. But this stone is, I think, is present only in Egypt, as far as I know, Yani. They used to do everything. They use like cups, like plates, or even the canopy jars where they preserve the vital organs of the mummies, the mummified bodies of the kings of the ancient Egyptians. They used to put them in canopy jars made of alabaster. Alabaster is a stone that is very smooth and pale yellow in color. So this is why the term alabaster skin. Because the skin of a male patient with pan-hypopituitarism, being pale and hairless, resembles alabaster in this regard. Is it clear? So if you read this term, alabaster skin, in any textbook, now you know what is meant by that. Any problems so far? Any problems? Okay. Now, one of the important causes, I mentioned already, one important cause of pan-hypopituitarism, which is Sheehan's syndrome, all right? But another equally important cause of pan-hypopituitarism is empty sella syndrome, empty sella. Remember the anatomy I showed you earlier in this session? This is a sagittal MRI of the pituitary gland, T1 weighted image. And this is the coronal MRI of the pituitary gland again, T1 weighted image, because the lateral ventricle and the suprasellar cistern and the third ventricle, they all appear black. So where is the area of the sella turcica? This is the sphenoidal air sinus. This is the sphenoid bone, or the sella turcica inside the sphenoid bone. And this is the optic chiasma. And this is the pituitary stalk. If you notice, it's going down almost to the floor of the sella turcica. Where is the pituitary tissue? It's not visible. The sella turcica appears black, as if it's filled with CSF. It appears empty, okay? Type. Let's look at the coronal cut. Here is the sella turcica again. You see, the bone appears white. This is the optic chiasma. This is the pituitary stalk reaching almost to the floor of the sella turcica. Where is the pituitary gland that I showed you earlier? It should have a concave or a flat upper surface, but here it's not visualized, as if the sella turcica is empty, okay? Why does this condition occur? Can somebody tell me? Why does empty sella turcica occur? I mean, why? What is this syndrome of empty sella syndrome? Why does it occur? Who can tell me? Shall I pick a name? Dr. Noor, would you like to answer? Dr. Noor Tariq, would you like to answer, please?
Yes, doctor. Could be secondary to ischemia or infarction?
Yes, it could be due to, very good. It could be due to a pituitary tumor that has undergone sudden hemorrhage or infarction. So it became shrunken, okay? So in the body, there is no vacuum. Whenever a structure decreases in size, there its place has to be taken up by something else. So in that case, it's going to be replaced by CSF. Or the other explanation is that there is, remember the anatomy, the sella turcica is like it's like a space like that, but it's covered, it's like a box, it's covered, the upper surface is covered by dura matter, right? And in the center of the dura, there is an aperture through which the pituitary stalk can pass, okay? Sometimes this aperture is too wide, allowing some CSF to go down from the third ventricle or the suprasellar cistern down to the sella turcica, compressing the pituitary against the pituitary stalk. It can be, against the floor of the sella turcica. It can be compressed against the floor, against the anterior wall, or against the posterior wall, depending on the direction of compression of the CSF. Is it clear? Thank you very much, Dr. Noor. Very good. Is it clear? Any problems with the empty sella syndrome? Usually what is written in the literature is that most cases with empty sella syndrome, they have normal anterior pituitary function, but only a minority of cases they can present with pan-hypopituitarism. All right, so remember, empty sella may cause pan-hypopituitarism. Any problems so far? Any problems? Now, let's discuss acromegaly. Acromegaly, we have seen a patient, right? You have seen a patient in the scientific meeting, and the patient that was discussed yesterday was acromegaly with high prolactin, right? If I remember correctly. Is it true? So let me discuss acromegaly in terms of, I'm going to revise it, in terms of clinical features. You know that the clinical features we have the symptoms and the signs. Regarding the symptoms, always remember any disease whatsoever, not only endocrinology, any disease whatsoever having to do something or affecting the external appearance of the patient, female patients come running to the physician, okay? So female patients, they come running, telling you, look at my face, doctor. See, my face has changed in appearance. Okay, of course you can notice that her face changed, but take the words from her mouth. Let her talk. How did your appearance change? She may have an old picture with her. See, this is my picture like 3 years ago. See how I look like today? Okay, you will notice, she will tell you, my face appears to be swollen. My facial features have become coarse. My nose has become big in size. My lips have become big in size. My tongue has even become big in size. And we had one acromegaly patient complaining that she has like stuttering in her speech. Not stuttering, but I mean she has this dysarthria. She says my speech has become different than before, as if my tongue is occupying my whole mouth cavity, and it affects the way I pronounce letters. These were her exact complaints. Depends, of course, on the intelligence of the patient, what she noticed. And she will also tell you, my hands have increased in size. A patient that we had, she used to wear a wedding ring. She said my wedding ring was so tight that it was about to cut off my finger. I tried to remove it in all possible ways, using soap, using wax, but no way. I had to go to the jeweler shop to have it cut off from my finger. Okay, and we had also an acromegaly patient who complained that her feet increased in size. She used to wear shoe size 37, but now she cannot find appropriate shoes her size, I mean, in the female division of the shoe shop. So she has to go and buy her shoes from the male division. And of course, she says the shoes in the male department are not very feminine. So she tried to look for a shoemaker to make appropriate feminine shoes, feminine looking shoes for her size, which became 44. Imagine 44, a lady wearing shoe size 44. And then, of course, she can complain of headaches. The headaches are, in particular, they can be like sphenoidal, like here, vertical, and bitemporal, okay? She can complain of excessive sweating. Why do you think she will complain of excessive sweating? Who can tell me? The patient is euthyroid. She doesn't have any problem in the thyroid gland. But why does she complain of excessive sweating? Who can tell me?
Hypertrophy of the sweat glands happens?
Yes, very good, very good. Who was it? Who answered? Who answered? Because very good, yeah, Dr. Anu. Excellent. Okay, so remember, sweat glands and sebaceous glands are part of soft tissue, okay? So in acromegaly, there is enlargement of the soft tissue as well as enlargement of the cartilage and bone, okay? So this is why there is excessive sweating. There is also visual deterioration. This visual deterioration can be in the form of reduced visual acuity. And we had a patient, a male patient. He was a 32-year-old young gentleman working as a builder, banna yani, okay? He wore the very thick eyeglasses, you know, كعب كوباية, the ones that you can see the eyes very small in the center. He didn't notice, he didn't complain that he had this deterioration of visual acuity. All he complained of was what? Joint pains, particularly in his knee joints, with knee clicking. So where did he go to have his knees checked? He went to the physical therapy department, physical medicine department. There, of course, they noticed that he had the typical acromegalic facies, typical acromegalic features. But he didn't complain of anything except the joint pains because they hampered him from doing his job, going up the sa'ala and the scaffolds and going down the scaffolds all the time at work. He had great difficulty, okay? So there they told him, yes, you have problems in your knees, but these problems are due to the original disease, which is a problem in your pituitary gland. So they referred the patient back to us. When the patient came to us, we noticed the full-blown picture of acromegaly, like I'm going to show you in a minute in the pictures. And when we asked him, he had visual deterioration. Yes, he was wearing these very thick eyeglasses since several months. And not only that, but he had also visual field defects, like I'm going to show you. He had bitemporal hemianopia, okay? And he had also impotence and poor libido, but since he was not married, he was embarrassed to tell us. but we asked him in private, so he admitted that he had impotence. And he had deepening of the voice. Remember, male patients or male subjects, they have already deep voices. So it's natural that they have deep voice. And even if their voices become deeper, yani they may not notice, or it doesn't make any difference to them. But this is very significant in female patients. All right? Why do you think deepening of the voice occurs in acromegaly? Who can tell me? Huh? Who can tell me? Always try to know why. طبعا يعني not everything we know the reason behind, but mostly we can know why. Why do female patients, or in general, يعني acromegalic patients, suffer from deepening of the voice? Who can tell me? Huh? Who can tell me? Very easy. Shall I pick a name? Huh?
Hypertrophy of the larynx.
Type. يعني the larynx, it's composed of two things: the cartilage, the laryngeal box. Okay, it's like, remember the orchestra? Did you watch the opening ceremony of the Grand Egyptian Museum? There was a very, very big and very nice orchestra. Did you notice the string instruments? There are several. The smallest of them is the violin. It has a high-pitched soprano. Okay, the larger one is the viola. It has a deeper pitch. Okay, and the larger one, the violoncello. Okay, the player, the musician, plays the violoncello standing. All right, and the even bigger one is the contrabass. All right, it's the biggest of the string instruments. It has the thickest strings and the biggest resonance box. The same occurs with the human larynx. The larger the laryngeal size, the deeper the voice. Not only that, but also the laryngeal, the vocal cords. Okay, the vocal cords in women are usually thinner than those in men. So if they become thicker due to soft tissue enlargement in acromegaly, the voice becomes deep. Is it clear? Does it make sense? Okay. And goiter. Goiter means enlargement of the thyroid. This is part of soft tissue enlargement. Okay. And there is tiredness. So the male patient I told you about was feeling tired all the time. He had also muscle weakness, and this muscle weakness tends to be to affect the proximal or the shoulder and the thigh muscles. So like for instance, we had a female patient with acromegaly. She used to tell us she had long hair, mashallah, till the middle of her back, but she couldn't comb her hair. Why? Because this maneuver, if you can still see my picture, she couldn't raise her hand above her head to comb her hair. So what did she do? She asked her daughters to comb her hair for her, but then she got tired and she cut off her hair à la garçon, like men, to make it easier for everybody to comb her hair. Also, she used to wear a headscarf and tie it as a knot on top of her head. She couldn't do this maneuver, if you can still see my picture. Okay, so her daughters did it for her as well. And when she was standing in the kitchen, she couldn't bring something from a shelf high up above the level of her head, or she couldn't put anything on that shelf, because she used to tell us she had pain in the shoulders. When we analyzed the pain, we discovered it was weakness rather than pain. Okay, she used to tell us دراعاتي مخدلة, like heavy. The upper arms were heavy. Okay, and in the lower limbs she couldn't walk up the stairs. Why? Because we use the flexors of the hip joints to walk up the stairs. Okay, and at home she had this Arabic toilet, الحمام العربي. Did all of you all of you know what an Arabic toilet is? Dr. Moliso, did you see an Arabic toilet before? Huh?
Yes.
Okay, great. So she had an Arabic toilet at home because she was living outside of Alexandria in a rural area. So she couldn't stoop over this Arabic toilet. So she asked her husband to exchange it with the regular one that all of us have at home. It's like a stool, right? So even though she couldn't rise from this hammam afrangi, or this toilet, because she had to support herself because of weakness of the thigh muscles. Also, she used to tell us, she told us that she used to sit on the floor on a rug with the rest of the family members drinking tea in the afternoon. She couldn't do that any longer. Why? Because she couldn't rise from this sitting position. She had to ask the rest of the family members to help her get up because of the muscle weakness in the thigh muscles. All right. So this can be a symptom, right? But if it's not a symptom, if the patient didn't complain of it, you have to look for it as a sign, like I'm going to tell you in a minute. Okay. And acromegalic patients can complain also of breathlessness, of pain and tingling in the hands and feet. Why? Due to carpal tunnel syndrome. All right. Again, if it's not a complaint, you have to look for it as a sign by doing the Tinel's and Phelan's tests, like I'm going to show you in the videos in a while. And they can complain of polyuria and polydipsia because they develop secondary hyperglycemia, I mean secondary diabetes mellitus. Because of hyperglycemia, which may be severe, they can develop polyuria and polydipsia. Okay? Of course, like I mentioned, old photographs are frequently useful. If you can compare the facial features of the patient now, presenting now, with those in the past. And of course, you need to also to ask about symptoms of pan-hypopituitarism, which may be also present, since acromegaly is due to growth hormone secreting macroadenoma. A macroadenoma is a pituitary tumor that is more than 1 centimeter in all directions. So far, any problems with the symptoms? Any problems? Let me discuss the signs. The signs, these are the manifestations that you as a physician look for while examining the patient, as I mentioned. You will notice prominent supraorbital ridges, okay? This is normal for a male. Remember your anatomy? We used to study the difference between a male and a female skull a long time ago when we were in the second year. I don't know if you studied such things or not, if you remember them or not even. So it's normal for a male, but for a female to have prominent supraorbital ridges, this is highly abnormal, okay? And prognathism. What does prognathism mean? It means elongation of the mandible. Normally, when you ask somebody to show you your teeth like that, if you can see my picture, the upper incisors are in front of the lower incisors, right? But whenever the lower jaw elongates, this will bring the lower incisors to be in front of the upper incisors. And we had a female patient, she had a very nice complaint, actually, very clever complaint. She told us, I cannot bite my sandwich. I have to cut a bite by hand and then put it put the bite in my mouth and then chew it. Why can't you bite it? Because my jaw is maloccluded. It doesn't close properly because of this prognathism. And mind you, in the exam, in OSCE exams, for example, don't just assume that all acromegalic patients will have prognathism. It's not a must that all these symptoms and signs I am telling you about now, for the sake of revision, are present in every acromegalic patient, okay? So just ask the patient, please show me your teeth. He will do like this or she will do like this. If you don't find prognathism, for heaven's sake, don't say there is prognathism. And don't say there is prognathism without doing this maneuver, okay? Because the examiner is actually watching you, how you examine the patient, how you are examining the patient, which maneuver you did, which maneuver you didn't do, and so on, okay? In addition, there is interdental separation. The bone enlarges longitudinally and it enlarges in width as well. So if you find that there are spaces in between the teeth, upper or lower, there is, so just ask the patient, were your teeth always like that? If the patient tells you yes, خلاص, this is something congenital. There are some people like that. But if the patient tells you no, particularly if the patient is a female patient, she may complain, look at my teeth, they are very ugly now, they are separated. And the food items, they tend to lodge between my teeth because of the spaces in between, okay? And then large tongue. Remember the patient who told us that I have difficulty in speech because of my large tongue? This was a symptom. But when you ask the patient to protrude the tongue, you will notice the tongue is very big, like I'm going to show you in the pictures. Okay? Macroglossia. Now there is hirsutism. This term hirsutism means development of terminal hair in androgen-dependent areas in a lady. So we can't say a male has hirsutism because normally all men, they should have normal body hair. Now let's scrutinize the definition of hirsutism. What is terminal hair? Who can tell me? What is terminal hair? Who can tell me? Terminal hair is the dark, coarse, thick hair like the hair present on the bodies of male subjects. This is terminal hair. So what are the androgen-dependent areas? Androgen-dependent areas. Who can tell me? Does somebody know?
Upper chest and back and the upper arm, upper thigh.
Yes. And the lower abdomen. Very good. And the mustache and the beard and the sideburns. Okay. So these are the androgen-dependent areas in a lady. Okay. And we have, of course, a score which is called Ferriman-Gallwey score, through which these 9 areas get a rating from 0 to 4. So the minimum is 0. 0 by 9 is 0. And the maximum is 36. Okay. And we say there is hirsutism whenever the score is 16 or above, right? So hirsutism is applied only for female patients, all right? طيب, why do you think hirsutism occurs in acromegaly? Why? The same mechanism like excessive sweating. The hair follicles, they tend to enlarge. They are part of soft tissue. So this will cause hirsutism, okay? And the patient will also, particularly female patients, they can complain. This can be a complaint, by the way. She will tell you, I feel my skin is greasy and oily all the time. I take like 5 times a shower per day, but still I can come out of the shower feeling oily and greasy. Thick, greasy skin due to enlargement of the sebaceous glands in acromegaly, right? The hands are spade-like زي الجاروف كده, okay, like a spade. And the feet are also enlarged. I will show you the pictures. And in particular, you notice that the fingers are broadened. They are broad. They are sausage-like, okay? And there is enlargement of the thenar and the hypothenar eminences in the hands, so that when you shake hands with an acromegalic patient, whether male or female, you feel a doughy sensation, as if you are زي العجينة, okay? As if you are touching dough, very soft, okay? And in the feet, you will notice the feet, they are increased in length and in breadth as well. And the toes are also broadened, but you will notice what is very prominent is the prominent heel pad. The heel protrudes. If you look at the patient from the back, the heel protrudes like that from the slippers of the patient, okay? And tight rings, this can be a sign as well, because you know the rings, they have sizes. The patient can tell you, I used to wear ring size 18, now I wear ring size 30, okay? So this means the finger has become thicker than usual and broader than usual. Carpal tunnel syndrome, as I mentioned, it can present with pain and tingling as a symptom, or if the patient didn't complain of it, you have to try and elicit it, like I will show you in the videos by eliciting Tinel and Phelan's signs, all right? And the patient will have a colonic enlargement with development of colonic polypi. How can you detect presence of colonic polypi? By screening. How do you screen for colonic polypi? Who can tell me? Who can tell me? Who can tell me? We are losing a lot of time. You do the CBC, okay? If you find iron deficiency anemia in an acromegalic patient, okay? whether male or female, you need to do the next test you ask for is what? Occult blood in stools. If occult blood in stools is positive, then you have to send the patient to do colonoscopy for detection, for screening of polyposis. Why is this important? Because colonic polypi tend to be precancerous. Okay, this is very important. Okay, and then you need to check the visual fields of the patient by doing the confrontation test. Alas? And do you all know how to do the confrontation test? Huh? Answer me, please. We are wasting a lot of precious time.
Yes, doctor.
Okay. And if you doubt that there is something wrong with the visual field of the patient, and even before you send the patient to surgery, like our patient, you send her or him to ophthalmology to have a Goldman perimeter study, perimetry, okay, to visualize the field effect. Galactorrhea, as I mentioned, it can be a symptom, but it can be also a sign. You can see it and you can look for expressible galactorrhea, a milder degree of galactorrhea. And of course, acromegalic patients tend to have secondary hypertension. They tend to have edema. They may have heart failure, arthropathy, like the young gentleman I was telling you about. When we examined him, both his knees were swollen. He had bilateral knee effusion, and he had crepitus. You know what crepitus is? A grating and creaking sensation when trying to move the knee passively. Okay, and of course he had proximal myopathy. How did we examine for proximal myopathy? We tested the muscle power of the flexors, the extensors, the abductors, and the adductors of the shoulder and pelvic girdle muscles. Okay, and of course, if you doubt that the patient has glucosuria, you can, with the dipsticks, you get a urine sample from the patient and you check for glucosuria with the urine dipsticks. So far, any problems? Huh? Any problems? Okay, so this is a summation of all the clinical manifestations of acromegaly that I have mentioned. A patient, male or female, who presents with enlarged hands and feet, coarsening of the facial features in the form of enlarged nose, enlarged tongue, enlarged lips, supraorbital bulging or prominent supraorbital ridges with prominent zygomatic bones, prognathism with the dental malocclusion and interdental separation, with a headache and thyroid gland enlargement. They may have skin tags, particularly ladies. Also, they complain of these. She can tell you, look at these hasanat or nevi. They can be present all over the face, the neck, the chest, upper chest, front and back. These are not nevi, these are skin tags. They may be sessile or they may be pedunculated. Ladies can have galactorrhea. They can complain of increased perspiration, increased sweating, oiliness of the skin. They can have cardiomegaly, hepatomegaly, nephromegaly, splenomegaly, and enlarged colon with colonic polypi as part of generalized soft tissue enlargement, and they can have carpal tunnel syndrome and osteoarthritis. In that case, it is secondary osteoarthritis, because remember, osteoarthritis is a degenerative disease of middle age, so it occurs in the 40s plus. But remember the young gentleman who came to see us, he was 32 years old and he had osteoarthritis of both knees. So obviously it was a secondary osteoarthritis. So far, any problems? And of course, if you do the imaging, you will find deformed sella turcica due to a pituitary macroadenoma. So far, any problems? Okay, so let me show you. Remember when I told you old photographs are useful? This is a young gentleman. Remember, he was very handsome when he was young. Over the years, you see, acromegaly is a chronic disease. It can take a lot of time to develop. So over time, you see, he started developing acromegalic features until he had a full-blown picture of acromegaly. Some of you will tell you that it's a normal finding that elderly patients, elderly subjects who are normal have enlargement of their nose, their lips, and their ears. I tell you yes, but not to the extent of acromegalic features, right? This is a very interesting case. See this lady? This is her her. This lady is Mary Ann Webster. She lived in the 19th century. She was born in 1874 and she died in 1933. She was a nurse living in the UK. Okay, she was very handsome. She married a gentleman called Thomas Bevan. All right. So according to the social norms in Europe, whenever a lady marries a gentleman, she acquires his family name. So she became Mary Ann Bevan, right? Okay, she lived happily and with her husband, she had 4 children and she was very successful at work, very loved from her colleagues and from the patients. But all of a sudden, she started developing acromegaly until she became like that. She turned to be very ugly. And her external appearance, her facial features were very frightening to the patients. So they dismissed her from work. Unfortunately, at the same time, poor Mary Ann, her husband passed away. So she was confronted with no job and no supporting husband, and she had to provide for herself and for 4 children. So what did she do? She had to go work in a circus. You see, this is her again. She, the circus, like in the past, and even today, even they bring, like dwarfs, the regular caoutchouc. These are oddities in human beings. They bring them to the circus to entertain people. So people come actually pay money to watch this ugly lady, Mary Ann Bevan. She called herself the world's ugliest woman on earth. Remember, she had to tolerate all the humiliation of being looked at, and maybe she heard some humiliating sentences like, what an ugly creature, or maybe some people spit at her or something like that. She had to tolerate that poor lady in order to supply for her children. If you look at her face only, like here or like here, you would say this is a man, right? But here she is wearing a nice satin dress with nice embroidery and flowers. So here you can tell she's a lady. All right. So this is a picture from history. I mean, this is a true acromegalic patient who lived in the past. But of course, back then they didn't know anything about acromegaly yet. They didn't know any treatment modality. So I assume until she died, she remained acromegalic. Okay. And here is to show you the increased size of the hands. You see, the grid lines are spaced 1 centimeter apart, the lines, okay, in every direction. So remember, the hands, the fingers of this gentleman are broad. Look at your own fingers. Yeah, the finger is like only 2 centimeters in breadth, but here 3 or 4 or even 3.5 centimeters in thickness. And here you can notice the increased thenar and hypothyroid eminence. This is what gives you the doughy sensation when you try and shake hands with an acromegalic patient. And this is an acromegalic patient. You can notice the facial features, the acromegalic coarse facial features, and he has even a nasal prong inside. And this is the hands of the patient, the hands, the right hand of the patient. This is the left hand of the physician, the treating physician wearing the watch. You see, his hand size is relatively big, 6.5, but as if it's drowning in the patient's hand, because obviously the patient's hand, it's much bigger. Here you can see the same. These are spade-like hands in an acromegalic patient with sausage-like fingers and increased soft tissue of the thenar and hypothyroid eminences. Okay? Again, here the spade-shaped hands of 2 acromegalic patients with broadened sausage-like fingers. And here again, the patient's hand and feet were photographed with after taking his permission. Here you notice the soft tissue of the heel here. It's very prominent here to the back and here as well. Okay, and the toes are also broadened. Okay, and these are the facial features in acromegaly. Those of you who are obsessed with the James Bond movies, the old James Bond movies, there was this person named Jaws. Remember him, or Joe? Remember him? He used to look exactly like this one. And we have an Egyptian actor who appeared in the sitcom El Kibir Awi, if you remember him, Ashraf. He had exactly the same facial features with elongation of the face, prominent supraorbital ridges, prominent zygomatic bones. And here you can notice even some facial asymmetry, like we discussed yesterday, okay, due to different sensitivity of the growth hormone receptors. The IGF-1 receptors, with the large nose, large ears, and thickened lips. And again, here you can see the facial features in acromegaly in front view, but inside view, you can appreciate more the frontal bossing or the prominent supraorbital ridges, the large nose, the large ears, and the large lips, and the protrusion of the mandible. But here you can notice these are the skin tags I was telling you about. These are sessile skin tags, okay? And here are some pedunculated skin tags. These are the ones that female patients call nevi. These are not nevi. These are skin tags. And they can also represent a skin manifestation of insulin resistance, like here. You see, this is acanthosis nigricans as well. This is a skin manifestation of insulin resistance, which occurs commonly in acromegalic patients. All right. Here again, inside view, you can appreciate the facial features of acromegaly in the form of prominent supraorbital ridges, prominent zygoma, large nose, and large ears. And here, of course, also the mandible is a bit elongated. But we cannot say that this patient has prognathism because we didn't ask him to show us his teeth. Here again, you notice a younger patient with acromegaly with the facial features, large nose, large ears, thickened lips. And here, of course, if you ask the patient to show us his teeth, he would have prognathism. Like here, of course, this is a different patient, but here you can see there is prognathism. The lower incisors are located in front of the upper incisors with interdental separation. Okay? Let me put the charger before my laptop goes off. Okay. 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 So here we asked the patient to show us his teeth, so we could say for sure that he has prognathism and interdental separation. Okay. Now this is another patient here in front view, and inside view he has frontal bossing or prominent supraorbital ridges, a large nose, thickened lips, and some prognathism, but it's not very clear like the previous picture, and some interdental separation as well. And here you can see the patient has large ears, and he's even wearing a hearing aid, and he has a large tongue, but not as large as this one. You see, this is typical macroglossia. See, the nose is very large, the lips are very much thickened, even the frontal bossing appears, and the tongue is very large. You see, very large. This patient may complain of this speech abnormality as well. Okay, like the patient that I mentioned to you earlier. And this is bitemporal hemianopia, like I mentioned yesterday. Imagine you are now sitting right in front of your mobile or your computer, and you're looking straight ahead. Imagine you are looking straight ahead. Without moving the eyes or the head, you can see what is on your right side, and you can see shadows of what there is on your left side, right? Right? Can you do that for me and tell me? Is that true? So this is the view, the field that the normal field. But suppose this is the decussation, okay? In the optic chiasma, the temporal fibers coming from the temporal retina, they decussate to the other side, okay? So if you have a tumor compressing from this side, there will be early, like the patient we saw yesterday, upper quadrantic, bilateral upper quadrantic temporal hemianopia, the black quadrant. And the inferior quadrant is grayish, which means that the visual acuity is markedly decreased here at counting fingers. But suppose the tumor compresses from the front, the patient will complain of, or she will have, or he will have lower bilateral, lower quadrantic temporal hemianopia, these black areas here. But the upper fields, upper temporal fields, the visual field, the visual acuity will be markedly reduced to counting fingers. But if the patient, suppose the tumor is compressing from below, exactly from below, okay, then both upper and lower temporal fields will be lost, will be black. So this will be the visual field, as if it is contracted, as if the patient is seeing through a tube. Okay, is that clear? Is that clear? Any problems so far? Okay, now let's shift to imaging in acromegaly. Imaging is very important. We have the plain x-rays. Plain x-rays of what? Let me first show you. Remember when I told you any x-ray, any imaging modality, when you see it, you try to hold it correctly and you try to determine which x-ray, which imaging modality this is. So this is a plain x-ray skull in lateral view of a normal person, But here they zoomed in on the area of the sella turcica, okay? So this is the anatomy, the anterior clinoid process, the anterior wall of the sella turcica, the floor, the posterior wall, and the posterior clinoid surface. And here the black area is the air inside the sphenoidal sinus. And here the sella turcica appears black because we didn't give any contrast and it is a plain x-ray. So the tissue doesn't appear. And in addition, if you try to put the tip of the little finger inside the sella turcica in a plain x-ray lateral view of the skull, it will accommodate only the tip of the little finger. It's as small as that. But now let's look at a plain x-ray skull lateral view in acromegaly. Here, first of all, you will find thickening of the skull vault. You see? The skull vault is not normal. This is not normal. There is hypopneumatization of the frontal, the maxillary, the ethmoidal air sinus, paranasal sinuses. Here, the arrow points at the frontal air sinuses. Hyperneumatization means they are more black than usual. They are larger than usual and they contain more air than usual. And if you look at the area of the sella turcica here, you will find that it is ballooned. It doesn't accommodate only the tip of the little finger. No, it is much larger. And sometimes you can see a double floor. Sometimes you can see erosion of the posterior wall or the posterior or the anterior clinoid processes. Okay. Here you can see also there is mandibular prognathism. Okay. But it's more evident in this plain x-ray skull lateral view. Here it's very evident that the mandible is enlarged such that the lower incisors come to be located in front of the upper incisors. There is also some interdental separation, as you can see, upper and lower. Okay? Is it clear? Am I going too fast? I hope you can follow me. And this is a plain x-ray on the hands in an acromegalic patient. The right hand, the left hand, this is an AP view, okay? You will notice there is increased bone density, okay? Because of thickening of the bone, there is epiphyseal widening. And there is tufting. If you look at the terminal phalanges of the fingers, and there is tufting of the terminal phalanges. So tufting of the terminal phalanges, this is a radiological term. It's not a clinical term. So it's a common misconcept and it's a common mistake that in the OSCE, you mentioned there is tufting of the terminal phalanges. You don't have x-rays in your eyes. This is a radiological term. And if you, in close up, if you can notice, normally the tip of the terminal phalanx is just rounded like that. But here you notice it's like mushroom shaped. You see? Mushroom shaped. Can you notice? This is what it means, tufting of the terminal phalanges. Is it clear? So it's a radiological sign. And here, this is a plain x-ray of the left foot, L for left foot of the patient with acromegaly showing increased heel pad thickness. Again, increased heel pad thickness, this is a radiological sign. our colleagues at the radiology department, they can measure on the computer with the cursor the thickness, the distance between the calcaneus and the end of the soft tissue. If it's more than 23 millimeters, it's suspicious. And if it's more than 27 millimeters, it's diagnostic for an increased heel pad thickness. But clinically, this is not a clinical term. When you examine the feet of a patient, you will notice that there is increased thickness of the heel and increased thickness of the soft tissue over the heel. Okay? Over the foot, yeah. The plantar aspect of the foot. Is that clear? Any problem so far? Okay, so now we come to MRI of the sella turcica. For the sake of discussion, I have included the MRI of pituitary microadenomas. Okay? Just for the sake of discussion, of course, you all know that growth hormone secreting pituitary tumors are nearly always macroadenomas. They are more than 1 centimeter in all dimensions, like the patient we saw yesterday. So this is a coronal MRI of the pituitary showing. This is in T1 weighted image because the CSF is black. Okay. This is the sphenoidal hair sinus, and here is the area of the pituitary gland. Here they gave gadolinium. Gadolinium is the contrast. So the pituitary gland became whiter than normal because it took up the gadolinium, but there is a filling defect inside it. This one, a sonolucent area. Not a sonolucent, I mean a lucent area in the left side of the pituitary gland. That didn't take up the gadolinium, and you notice the upper border of the pituitary became convex, and here is the pituitary stalk. You see, it is shifted to the left side, and this is the optic chiasma. So till now, the pituitary microadenoma is inside the sella turcica. It didn't encroach yet on the optic chiasma. So obviously this patient, or on the cavernous sinuses. So obviously this patient didn't have any visual field defects. Okay. Here again, the same picture of, the coronal MRI of a pituitary microadenoma showing, you see the arrow pointing at the microadenoma in the left side of the pituitary. This is the pituitary gland. It has taken up the gadolinium. This is why it became white in color. This is the pituitary stalk, and this is the optic chiasma. Okay, and the stalk is slightly deviated to the right side. Okay, and this is the left-sided lucent intracellular microadenoma. But what is usual that in acromegaly we have pituitary macroadenomas. So this is a coronal MRI of the pituitary showing, this is here the sphenoidal air sinus. This is the ballooned sella turcica. You can see there is a very large pituitary macroadenoma, okay, with moderate supracellular extension, compressing the optic chiasma. So here, of course, the patient would present with visual field defects by temporal hemianopia. And there is lateral extension. You notice here the upper border of the pituitary is convex, you see. We cannot visualize the stalk. And there is even a lateral extension to the left cavernous sinus, you see. Okay. And this is another picture of a huge pituitary macroadenoma. All the black arrows point at this. You see, the area of the pituitary is here, but the macroadenoma extended upwards, encroaching on the optic chiasma and even into the hypothalamus and even nearly reaching the corpus callosum. So it's a very large tumor, very large pituitary macroadenoma. Okay? All right? So far, any problems? Remember yesterday when we discussed the NOSP classification, this is another pituitary MRI in acromegaly in sagittal view, okay? T1 weighted image, since the lateral ventricle appears black, CSF appears black here in the fourth ventricle as well, okay? and there is hyperneumatization of the frontal air sinus. This is a ballooned sella turcica with the pituitary tumor encroaching upwards on the optic chiasma. Okay? Any problems so far? Can you still hear me? Type. Remember yesterday, this is the coronal view of another case with complaining of presenting with acromegaly. This is a coronal pituitary MRI in T1 weighted image, since the lateral ventricle and the third ventricle appear black. This is the area of the pituitary gland. Okay, and there is a macroadenoma extending to the right cavernous sinus, but it didn't encroach upwards on the optic chiasma. And here the pituitary stalk is not visualized, but the upper border of the pituitary is somewhat convex. Okay. Now remember yesterday when we discussed the NOSP classification, this is how it's written, KNOSP. Okay. So this classification is a commonly used system to determine the likelihood of cavernous sinus invasion. This is the pituitary adenoma, and this is the cavernous sinus with the internal carotid artery, okay, and the different cranial nerves. This is important for our colleagues in the neurosurgery department, and they define the 4 grades using 3 lines. These 3 lines drawn between the supraclinoid internal carotid artery and the intracavernous internal carotid artery on coronal MRI. This cannot be seen on the sagittal, only on the coronal. There is a medial tangent line, there is an intercarotid line, okay, and there is a lateral tangent line. So let me show you how it looks like. This is how it looks like on MRI. Actually, this is a coronal MRI, and here is the area of the pituitary. And this is the cavernous sinus, and these are the different lines, the medial tangent, the intercarotid line, and the lateral tangent line. Okay? And so NOSP grade 0 is, here is the tumor, okay? When the tumor is medial to the medial tangent line, right? Right. And this is NOSP grade 1, when the tumor is between the medial tangent line and the intercarotid line. Okay, and this is NOSP grade 2, when the tumor extends further between the intercarotid line and the lateral tangent line. Okay, and this is NOSP grade 3A. 3A, remember yesterday, Professor Tamer Shubini has told you that here the tumor extends beyond the lateral tangent line into the superior cavernous sinus compartment, right? And this is NOSP grade 3B, where the tumor extends beyond the lateral tangent line, but into the inferior cavernous sinus compartment, okay? And this is NOSP grade 4, where the tumor completely encases the internal carotid artery inside the cavernous sinus. Is it clear? Any problems so far? Is the NOSP classification clear to you now? More clear than yesterday?
Yes.
Answer me. Okay, great.
Yes.
Okay,
yes.
Okay, thank you. Now, the last thing I'm going to discuss in the area of the pituitary is craniopharyngioma. Actually, it's the most common pituitary tumor in children, but it may present at any age. The youngest patient with craniopharyngioma I have seen was 10 years old, and the oldest one was like 20 years old, okay? Although it is said that it is a pituitary tumor, actually, it doesn't arise from the pituitary. It's a cystic hypothalamic tumor, often arising from Rathke's pouch, right? The remnant of the Rathke's pouch. So it's often calcified, but it often mimics an intrinsic pituitary lesion since it extends downwards from the area of Rathke's pouch down to the pituitary gland. So this is how it looks like on plain X-ray lateral skull, lateral view, plain X-ray skull lateral view. You can see there is this, the white arrow points at the calcified area above the area of the sella turcica. So this is a supracellular calcification, but it has somehow extended downwards, eroding the sella turcica, the floor and the posterior wall. Okay, this is the plain X-ray. But on coronal MRI, you can clearly see that here, this is the area of the pituitary, but the tumor arises. There is a large cystic tumor within a contrast-enhanced thin shell. The rim or the shell of the tumor appears white because it has taken up the contrast, while the tumor itself is cystic, and it has compressed the third ventricle, causing mild hydrocephalus. All right. This is again a coronal T1 weighted image because the CSF is black. And here, this is the craniopharyngioma, how it appears like on an unenhanced CT. Unenhanced means that they didn't use any contrast. So bone CT relies on X-rays like a regular X-ray, but using the computer. It's axial. It's cut like that, if you can still see my image. The skull, this is the skull bone appearing white. And here, this is the much higher level than the area of the pituitary. There is, you see, a calcified cystic structure. The calcified area has the same tissue density like bone, appearing white. So it's calcified. And the cysts appear somewhat grayish black in color. And of course, this tumor has caused also hydrocephalus. You see, the lateral ventricles are dilated, and this posterior aspect of the ventricles is also dilated. Okay? So this concludes the first part of today's session, the first part. I suggest if we want to continue today, I can continue, but let us take 10-minute break or so to go walk or eat something, drink something if you like. But if you are tired and you don't want to continue, we can skip it and we can do it on another occasion. I was intending to explain to you the imaging of, I wanted to revise hypothyroidism and hyperthyroidism with the different signs and the different imaging procedures, and hyperthyroidism as well. So what do you want? You just tell me what you want. And I forgot to show you the video. I was telling you about on how to examine for carpal tunnel syndrome. Remember? You want me to show you the video? Huh? Can you answer me, please?
Yes.
Okay. Yes. Okay. Thank you, Dr. Walisu. Just let me open the video first. Where is it? Yeah. Where is the video? Okay, here it is. The video has sound in it, so I'm going to share it with sound, okay? So please let me know if you can hear, can see the video and you can hear it as well. Let me share the video. Let me first open it. Where is it here? 1 second. It's opening. The video is opening now. Okay, let me share the video. I'm going to share it with sound. Can you see? Can you see the video now? Huh? Can you see the video?
Yes, doctor.
Okay.
Yes.
Okay. Okay. Tell me if you can hear the sound.
Hey everyone, this lesson is on carpal tunnel clinical signs and examinations.
Is the sound
carpal
audible?
tunnel syndrome
Is the sound audible as well?
Yes.
Okay.
Yes.
due to a tunneling or a compression of the median nerve that runs in this area of the wrist here. So the first clinical test we can perform is called the Tinel's sign. And what that entails is by actually tapping, if we tap over the median nerve, if we elicit symptoms of tinglingness or numbness sensation over the palmar area of the first, second, third, and half of the fourth digit, that's the median nerve distribution. If we elicit symptoms with the Tenel sign of us tapping over the median nerve, that's a positive Tenel sign. The second test is called the Phelan's sign. Phelan's sign is what we call the inverted prayer sign. If we were to hold our wrists together like this for 60 seconds, so you get the patient to hold them like this, put pressure on, basically it's compressing the median nerve like it would in carpal tunnel syndrome. We push our hands together for 60 seconds. If we reproduce the same symptoms of numbness, tingling sensations, again in the distribution of the median nerve along the palmar surface of our hand, first, second, third, and half of the fourth digit, if we reproduce those symptoms, that is a positive Phelan's sign as well. So those are the two clinical tests and some of the signs and symptoms of carpal tunnel syndrome.
Okay, is it clear? Remember, carpal tunnel syndrome is a very important condition because it's not only seen in acromegaly, it can be seen in hypothyroidism as well. We'll just tell you about this when we discuss the clinical manifestations in hypothyroidism. And it is also seen in diabetes mellitus as well. But it can also occur in pregnancy, during pregnancy, or in simple obesity, or occupational. For example, if there is a computer engineer or a secretary who is sitting 8 hours a day for 6 days or 5 days a week for several months or even several years, holding the hands in a wrong way while typing or while using the mouse, either by hyperextending the wrists or hyperflexing the wrists, then over time the carpal tunnel will be compressed. As you noticed in this video, the doctor tapped over the median nerve using the middle finger. Here at the Faculty of Medicine, Alexandria University, we use the reflex hammer to tap over the area of the median nerve, like I will show you in this other video. But here the video is filmed in Southeast Asia, so we won't be able to understand what they are going to say, so I'm going to mute the sound. So in order not to distract you, but just to show you how it's done. Here, they use this type of reflex hammer that we most probably don't have in Egypt. You notice that he's tapping over the area of the median nerve, but the tapping here is very mild. No, it should be more vigorous than that, okay? But you shouldn't also cause pain to the patient. So this is the correct way of doing it. And in this other video, I'm going to show you, there is it's talking exclusively about the Phelan's test, how it's done. Every video I show you provides additional information, like here. Let me show you this video.
Hello, doctors. I am Dr. Don.
Can you see the video and hear the voice? Huh? Can you hear the voice?
Yes.
Okay.
Yes. Fellow of Championship Chiropractic in Las Vegas, Nevada. Phelan's test is an orthopedic test for carpal tunnel syndrome. The patient is seated in good posture. Want to make sure that their shoulders are not rolled forward and their scapulas are not retracted. Also, throughout the test, we want to make sure that the patient does not shrug their shoulders. The patient is going to flex their wrist to the maximum amount bilaterally and apply light pressure with the back of the wrist pressing against each other. They hold this position for 30 to 60 seconds.
This is very important. Remember, the elbows have to be widest apart, and there has to be an angle of 90 degrees between the palmar surface of the hand and the forearm. And the patient needs to hold this position for 30 to 60 seconds before you can say the test is positive or negative, okay?
A positive test would be pain, numbness, tingling, or burning along the distribution of the median nerve in the wrist and hand. That distribution is the thumb, the index finger, the middle finger, and the side of the ring finger closest to the middle finger. If these symptoms do occur, it is a positive for carpal tunnel syndrome.
So in this video, the additional information that was provided was what? The proper posture of the patient. The patient has to be sitting comfortably, not stooping forward, not retracting the shoulders, and not shrugging the shoulders. Very important. You have to do the technique correctly in order to elicit the sign properly. Okay, and this in this last video, there will be additional information provided about Tinel's sign as well. Tell me if you can see the video and hear the sound as well.
Hello everyone, this is Paul from Ortho-Eval.
Can you hear the sound?
Yes, doctor.
Yes.
Okay.
And today I want to talk about Tinel's testing, okay? So we're going to be doing a Tinel's at the wrist to help identify if somebody has carpal tunnel syndrome. Now, just a little something about Tinel's. It's important that when you do the tapping, it's nice and steady, nice and even, and you test it on both sides. There are people who will have many false positives with carpal tunnel syndrome, but the way you do it is you have the patient relax, you just expose the anterior aspects of the wrist, and you give just a nice little steady tap. You can use your finger, you can use a reflex hammer, but it's nice and steady. Now, what we're looking for here, I never tell the patient what I'm looking for. I ask them what they're feeling. So if they say they're getting kind of a shooting pain into any of the thumb, index, or middle fingers, or numbness into that area, anything like that, that's positive. That's a positive Tinel sign at the wrist. Okay, thanks.
In this video, additionally, he mentioned very important things. You have to, the tapping, we agreed upon that we use the reflex hammer, and if you use the triangular reflex hammer, you use the broad area, the broad part, because the median nerve is a large nerve, all right? So you tap over the median nerve, nice and steady, nice and even, right? Not gently like in the first video I showed you, in the second video I mean, okay? And the second thing he added here, very important, you have to test on both sides to avoid positive, false positive tests, right? And the second thing he mentioned is that we shouldn't ask the patient leading questions. Don't ask the patient, do you have numbness? Do you have tingling? No, just ask the patient while tapping, is there anything that you feel? If the patient tells you yes, so ask her or him, what do you feel? If he tells you the tap, no, this is not what you're looking for. If the patient tells you numbness, tingling, electrifying, or shock-like pain, this is a positive Tinel sign. All right? Is it clear? Any problems so far? Huh? Any problems? Okay, so you tell me. Do you want me to continue or are you tired? You tell me. I'm waiting for you to tell me something.
I think we can continue.
So this is what Dr. Moliso thinks. What about the rest of you? Dr. Dalia Izzat, Dr. Heba, Dr. Minnatullah Muhammad, Dr. Nadine Dawood, and Dr. Salma Muhammad, and Dr. Sameh, Dr. Wissam, Dr. Khulud. You want to continue on another occasion. Type before your exam or after your exam. This is the big problem, the big question, I mean, the big question.
We can continue today, doctor.
You can continue today. Type 2 to 1. The rest of you, I have still 9 students surviving. I have 9 students surviving this session. The rest of you, what do you think? The remaining 7, what do you think? The remaining 7.
We can continue today, doctor.
Dr. Khulud, you want to continue today? Dr. Nadine, okay, you can continue today. Okay, so I suggest that we take 10 minutes break because I want to go drink something. My saliva has dried up from the excessive talking. I need to go drink some water and walk a bit, walk around. So I suggest we return at 10. Is that okay by you? Okay?
تمام يا دكتور.
Okay, okay. See you in 10 minutes, inshallah. Thank you. Okay, are we back? I see only two of you, Dr. Hiba and Dr. May. Are the remaining students coming? Can you hear me? سامعيني يا جماعة ولا إيه؟ لو حد سامعني يرد عليا بس بليز. Okay, can you hear me? Can you hear me?
Yes, doctor.
Okay, okay, thank you for answering. After 1 minute, record time. Are the remaining students coming back or what? Am I going to talk to only 4 people? Are the rest of you coming back?
اكتب لهم على الجروب يا دكتور.
طيب, okay, thank you. طيب, any problems so far? Was I too quick? Was there too many, was there too much information? I suppose this is a revision. I suppose you know all what I have said, yeah, right? Why don't you answer? Yani, any question deserves an answer, even if the answer is I don't know, right? But it's not yani it's not really very polite not to answer your professor. Type. Shall I start or shall I wait for the rest to come? There are only 5 of you remaining. Is somebody else coming?
ممكن نديهم 2 minutes كده يا دكتور ولا حاجة.
طيب, okay, ماشي. 2 more minutes. كلوا من وقتكم على فكرة. طيب, any problems so far? Anything that was difficult in the previous part? A simple yes or no would do. Thank you. Any problems in the previous part? Anything that is not clear? Let me ask you in a different way. Anything that was clear? Still no answer. Very odd. I don't know, Yani, which questions you are going to answer. I hope you will answer in the exam, at least, when you are asked. Anyway, 1 more minute, and I will start, inshallah. In the meantime, you have responded already. Okay. In the meantime, I'm going to put the minute. This is not it. This is it. This is not it again. Okay. Okay, you can hear me. Yeah, you have a problem with your microphone, Dr. Moliso, it seems. Okay. Let me put the link for the evaluation form in the chat of Microsoft Teams until your colleagues come back. Sincerely hope you will be able to see it or find it. Okay. I'm admitting 2 students. Okay. Okay. Would you please check the chat and see if you can see the link for the survey of today's session? Can you please tell me if it's visible for you or not?
It's visible.
Okay, great. Yeah, don't do it now. It's for later. خلاص? So I assume nobody else is going to join. We are at nine students again, like before. 8. We are 8 students now. All right, so let me share my presentation and please let me know if you can see it or not. Can you see it now?
Yes, doctor.
Yes.
Okay. Is it slideshow or small?
Not
Small.
small.
Okay. And now, is it slideshow?
Yes.
Yeah.
Okay. Is it moving or is it fixed?
Moving.
Moving, great. Okay, so the intended learning outcomes of this other session is that by the end of this session, you will be able to list the symptoms and signs of hypothyroidism. It's a revision, remember? You will be able to detect the atypical presentation of hypothyroidism in children, young women, and elderly patients. You will be able to enumerate the symptoms and signs of hyperthyroidism. You will be able to diagnose the presentation of hyperthyroidism according to the etiology. And again, you will be able to detect the atypical presentation of hyperthyroidism in children and the elderly. And you're going to be able to differentiate the type of goiter in the different causes of hyperthyroidism. You're going to be able to diagnose the different eye signs in Graves' disease. These are very important. I don't know if you have seen them on real-life patients or not, but they are very important. And you will be able to describe the different methods of detection of exophthalmos. This is again very important. And you will be able to differentiate the different types of thyroid nodules. You have discussed thyroid nodules, but unfortunately I couldn't attend, so I'm not sure what exactly you have discussed, but I'm going to lay particular stress on the imaging of thyroid nodules, right? And then you are going to be able to describe the different imaging techniques in thyroid diseases, namely thyroid ultrasonography and thyroid scintigraphy, okay? Now, coming to hypothyroidism, the clinical features include, again, the symptoms, the complaints of the patient. The patient will complain that she's feeling tired all the time. She feels malaise as if she's sick. And ladies, remember, hypothyroidism is a disease of predominantly ladies, right? It occurs more frequently in women than in men. So again, ladies complain of more of the cosmetic appearance. She will complain about weight gain. She will tell you, I don't eat anything, but in spite of that, I keep gaining weight. I'm following with a dietitian, but in spite of that, I don't lose weight. I still keep gaining weight. Some patients, though, they feel anorexia, or they complain of anorexia or loss of appetite. Okay, the most important complaint is cold intolerance. This particularly causes a lot of problems at the female ward. You know, if you have seen it, the female ward at our endocrine division is near the seaside. So it has a lot of windows opening into an open area, like a garden near the seaside. So in summertime, there is a very nice cold breeze coming into the ward. And whenever we have a hypothyroid patient, she's wearing all the clothes that she has at home, and she even brings an extra blanket with her to the ward when she's admitted, and she keeps quarreling with the other patients who feel hot because of summertime. She wants to close the windows, an eternal problem, yeah. And the patient will complain of having poor memory. I can't remember where I put my eyeglasses. I can't remember where I put my keys, okay? because hypothyroidism tends to occur also in older patients, like 50s and above, right? And female patients, again, will complain of change in appearance. Look at my face, doctor. Look at my face. Of course, you see that she has hypothyroid faces, but take from her own complaints. Take from her what she's complaining about. Yes, what happened to your appearance? She will tell you, my face is swollen, my neck is swollen, my eyes are puffy, and I have pallor in my skin. My skin appears pale, it's dry and rough and scaly, and I have swollen nose, swollen lips, my tongue appears to be swollen as well, and my eyebrows appear to have lost some hair, particularly on the outer thirds of the eyebrows. And some patients complain that the eyebrows are totally lost, and the scalp hair appears dry, brittle, and coarse and poorly managed. Okay, and the patient may complain of depression as well, but usually depression is, since it is a psychosis, one of the psychoses, the patient doesn't feel insight. She doesn't have insight that she is sick. So her husband or her children, they will complain, my mother has become depressed over the past few months, okay? And if the patient is a male, he will complain of poor libido again, poor libido, or weak, poor sexual desire. And maybe he will have also impotence. Why do you think this is? Who can tell me? Why does poor libido occur in male patients with primary hypothyroidism? Why? For the sake of time, if you don't know, just tell me, because we are losing a lot of time and we have still to cover a lot.
I don't know, doctor.
Okay, thank you for answering. Remember the physiology. I always tell my students endocrinology is a very easy branch of internal medicine because it relies on, to a great extent, on the feedback loops of physiology. Remember, in hypothyroidism, what happens is primary hypothyroidism, the disease is in the thyroid gland itself, okay? So there is poor secretion or decreased, diminished secretion of T4, 80%, and T3, 20% from the thyroid gland. This will lead to what? Feedback stimulation of the anterior pituitary to increase TSH secretion. But not only that, it will also feedback to the hypothalamus to increase secretion of TRH, thyrotropin releasing hormone. Thyrotropin releasing hormone will go down the anterior pituitary to the stalk, pituitary stalk to the anterior pituitary, where it stimulates secretion of both TSH as well as prolactin. Okay, so this is why in primary hypothyroidism there will be hyperprolactinemia. In men, this causes poor libido and impotence. In women, it will cause oligomenorrhea, amenorrhea, and galactorrhea. All right? Agreed? Is that clear? Does it make sense?
تمام يا دكتور.
Okay. Type goiter. I have put it in a different color. Why? Because not all patients with primary hypothyroidism have goiter. Only if they have iodine deficiency, if they have dyshormonogenesis, or if they have Hashimoto's thyroiditis, they can have primary hypothyroidism with enlarged thyroid gland. Remember that, all right? Okay. Now, as I mentioned, dry, brittle, unmanageable hair, dry, coarse skin, arthralgia, painful joints, myalgia, painful muscles, muscle weakness, again, like I mentioned earlier with the acromegaly. I will not repeat. It affects the proximal, the shoulder, and the thigh muscles. Some patients may complain of stiffness, but it's not very common. What is more common is muscle weakness. And of course, all patients complain of constipation. In order to detect that they have constipation, you have to ask about their normal bowel habits. How were the bowel habits before they developed primary hypothyroidism? The patient may tell you, I pass stools once every day. Okay, but how about now? No, once every week, or I need to take a laxative in order to pass stools. A very common complaint. And in addition, she will tell you, I strain at defecation. Straining at defecation completes the definition of constipation. Okay? So as I mentioned earlier, women in the fertile age group may complain of menorrhagia or oligomenorrhea or even amenorrhea. Right, let's discuss let's revise. How do we inquire about the menstrual history in a female patient? What are the items of menstrual history? What do you ask about in the menstrual history? Very easy. Who can tell me? This is history taking.
How often or how regular?
Okay.
And the duration of each period.
Type. You have to be systematic. I don't know who answered. I can see the participants who answered. Can you please tell me your name?
أنا سماء يا دكتور.
Okay, Dr. Sama. Thank you for answering. You have to be more systematic in order not to forget anything. First of all, the period occurs in the fertile age group. So you ask her about the age of menarche. When did she start having her periods? At what age? She may tell you 10 years, 11 years, at 12 years, whatever. Alas, this is the age of menarche. Then you will ask her, type, how frequent are your cycles? She will tell you, I get my menses once every month, or once every 3 weeks, once every 40 days. This is her normal, okay? So that when it changes, when the frequency changes, this is the frequency. Suppose she used to have her cycles once every month, okay? And then all of a sudden she started having the cycles once every 45 days. This is oligomenorrhea, okay? Oligo, this prefix is Greek, meaning decreased, yani decreased frequency of the menstrual cycle. The next thing you ask about is the duration. How long does the bleeding last? Some patients will tell you 3 days, 5 days, 1 week, whatever. Okay, this is her normal duration, because sometimes the duration can be either shorter or longer. The next thing you ask about is the amount of bleeding. How do we ask about the amount of bleeding in the menstrual cycle?
How many pads?
Exactly, very good. How many pads per day do you change? Okay, in addition, are there any blood clots or not? Because a lady will tell you, I change like 3 or 4 times a day and I don't have any blood clots. But then if she develops menorrhagia, this is increased menstrual flow, amount of menstrual flow, she will tell you, now I change like 10 times a day, 10 pads a day, and there are a lot of blood clots in my menses. Okay, this is very significant. Okay, now psychosis, it's like depression. I mentioned psychosis is a psychiatric illness where there is no insight. So this means that the patient may not actually complain of having a psychosis, but the husband or the relatives, the daughters or the sons of the patient will bring her to a psychiatrist complaining, my mother has developed psychosis, right? Deafness. Why does deafness occur in primary hypothyroidism? Who can tell me? Come on, it's very easy, huh? Remember, in primary hypothyroidism, there is deposition of mucopolysaccharide material all over the body, in the subcutaneous tissue, around the median nerve, causing carpal tunnel syndrome, like I have just shown you in acromegaly, okay? But here, in the mechanism of carpal tunnel syndrome in primary hypothyroidism is different. It's due to deposition of mucopolysaccharide around the median nerve. But in acromegaly, it was why did it occur? Because of enlargement of the carpal bones together with enlargement of the thenar and hypothenar eminences, compressing the median nerve in the carpal tunnel, right? So the end result is the same, carpal tunnel syndrome, but the mechanism is different. Now, why does a patient with primary hypothyroidism develop deafness? It can be due to deposition of mucopolysaccharide material around the vestibulocochlear nerve in the ear. This will cause deafness. But rarely in dysharmonogenesis patients who have Pendred syndrome, okay, this is a genetic disorder of where there are several defects in thyroid hormone synthesis, okay, and in addition there is a genetic defect in the transporter called pendrine, and this is why it is called Pendred's syndrome. All right. So in Pendred's syndrome, there is, in addition to the position of mucopolysaccharide material, there is in addition sensory neural deafness as part of this syndrome. All right. So, but this is a rare, I have seen only one family, very long time ago during my residency. It was a family, a man, his wife, and 5 children having Pendred's syndrome. All right, they had a huge goiter. Maybe I will show you the pictures. Okay, so now we know why deafness occurs in primary hypothyroidism. Of course, coma. Yani it's a crime to leave a patient with primary hypothyroidism until she develops myxedema coma, because myxedema coma is one of the important and dangerous endocrine emergencies. I have a lecture already on endocrine emergencies. I will agree with you on a time. I will give it online as well, where I'm going to discuss all the endocrine emergencies with you, but among them is myxedema coma. So don't leave your hypothyroid patient until she develops myxedema coma. Okay. Now, regarding the signs, these are the manifestations you look for while examining the patient. Let me tell you about a real life patient that I have really seen during my residency. Her name was Hagga Zainab. Hagga Zainab, she was in her 60s. She came sitting on a wheelchair brought in by her daughter into the emergency room, and she was putting her head on her chest like that, sleeping. Okay? Type. Okay, so I asked the daughter, Alfa Salama, what is wrong with your mother? She's sick, like you see. Okay, what is wrong with her? She told me, like that, she's sleeping like that all the time. She's sleeping all the time. And at home, when she's sitting on the sofa, she doesn't move. Of course, we have been sitting like for two plus hours now, but we move while sitting, right? We can cross our legs, the right over the left over the right, and so on. And she told me also, the daughter of the Hagga Zainab told me also that her mother, she goes to sleep, she goes to bed lying on her right side, and she keeps lying on her right side till morning. She doesn't turn in bed. Of course, all of us, we sleep on the right side because it's Sunnah and Rasul alayhi salatu wasalam. Okay, but we turn during the night, right? Not Hagga Zainab, poverty of movement. All right. Okay, I couldn't actually examine for ataxia, which is unsteadiness of the gait, because the patient was asleep. She was sitting on a wheelchair. And I couldn't also check for psychosis or dementia because the patient was sleeping all the time at home. So her daughter didn't notice any psychosis or dementia. But good thing that she brought her mother in due time, because if she had left her mother for 1 or 2 more days, her mother would have developed myxedema coma. So I tried to communicate with the patient. I asked her, Ismek Iya Hagga, what is your name? The daughter immediately, no, please raise your voice, doctor. My mother doesn't hear. Deafness, all right? Okay, so I neared my mouth to the patient's ear, and I raised my voice a bit. Ismek Iya Hagga. Remember, when you are deeply asleep and somebody wakes you up from this deep sleep, you feel disoriented. You don't look at whoever is woke you up, and you look in another direction. You can't concentrate properly. This was exactly the same thing that happened with Hagga Zainab, but after like 5 minutes. Imagine, it took her 5 minutes to open her eyes, not even look at me, look somewhere else, and understand my question and answer. Remember, this is mental slowness, okay? Notice what she told me. Zainab. And she fell asleep again. خلاص? So I noticed her deep voice. What about the voice? Is your mother's voice like that? Has your mother's voice always been like that? No, of course not. It has become deep. When did you notice that? When my mother became sick. Okay? Okay. I noticed also that Hagga Zainab had periorbital edema. Not only did she have periorbital edema, but she had a swollen face. She was actually swollen all over the body, swollen hands, swollen feet. She was obese because of ascites, and she had pericardial effusion. She had bilateral pleural effusion, and so on. Okay. Of course, goiter I put between brackets because Hagga Zainab didn't have goiter, right? Most probably she had an atrophic form of thyroiditis because the thyroid wasn't even palpable. Her neck was completely empty. Okay. She was wearing a veil, but from under the veil, I could see that the skin of her scalp was visible from under her scalp hair. She had dry, thin, and brittle scalp hair. So I asked her daughter, what about your mother's scalp hair? Was it always like that? She told me, no, whenever I comb my mom's hair, a lot of hair comes out in the comb. Okay, hair loss, a lot. She has a lot of hair loss. She had also, Hagga Zainab, loss of eyebrows. All of her eyebrows, not just the lateral thirds, were lost. Okay, she had dry skin, like I'm going to show you in the pictures in a minute, and she was also obese. Now, coming to peaches and cream complexion, what are peaches? Peaches, this is a fruit, okay? اللي هو الخوخ يعني. What is the color of peaches? Who can tell me? What color are peaches? الخوخ يا جماعة لونه ايه? What color are peaches?
Orange to red.
Yes, orange yellow. Yes, exactly. Orange yellow in color. And cream is the cream that we eat while eating gâteau or cakes, right? Cream is white. Type, what is this peaches and cream complexion? Remember, you will read this expression in foreign textbooks written in the UK or in the USA. Why? Because Caucasian persons, when they are healthy, they have a pink complexion. Their skin color is pink. When they develop hypothyroidism, okay, they develop this peaches and cream complexion. Why? Because in primary hypothyroidism, there will be hypercarotenemia. The beta carotene that we consume in the diet with carrots, with tomatoes, with red and yellow bell pepper, with mangoes, with cantaloupe, okay, or all the colored, the red colored food items or orange colored food items contain beta carotene. This is the precursor of vitamin A. Okay, so through certain enzymatic reactions in the body, beta carotene will be transformed into vitamin A. But since in primary hypothyroidism, the basal metabolic rate of the body is slowed down, so all the enzymatic reactions occurring in the body are slowed down, including conversion of beta carotene into vitamin A. So this will lead to accumulation of beta carotene in blood or hypercarotenemia, which will lead to deposition of beta carotene in the different tissues, including the skin. Okay, I will show you pictures thereof. All right, is it clear? This is a picture showing a patient with gross primary hypothyroidism. You notice she's elderly, right? And she has a swollen face, a swollen neck, and she has a swollen nose. Here we don't say the nose is enlarged in order to differentiate between the swelling of the nose and lips from the actual enlargement of the nose and lips in acromegaly. All right. Here you notice that the nasal bridge is depressed. She has apathetic look. This is an apathetic look, as if the eyes are sleepy. They are not opened properly. So this is what we call apathetic look. She has periorbital puffiness, and she has this you notice her cheeks and maybe the bridge of the nose are having this peaches and cream complexion. They appear orange yellow in color, but the forehead and the nose are, and the area of the above the upper lip appear pale in color. Here you notice her eyebrows are intact. Yani this means that not all the signs I have mentioned you will be able to find in the patient with primary hypothyroidism. So it goes without saying that in an OSCE exam or whenever you are examining a patient, mention only the positive signs. But there are here, for instance, it's a good negative sign if you say there is no loss of the outer thirds of the eyebrows, meaning that you have looked for this sign, but you didn't find it. And the scalp hair appears dry and coarse and brittle, as if, and poorly managed, as if the patient has just risen from sleep and she came immediately to see you without combing her hair. Okay, this is another lady. She's a Caucasian elderly lady. You see the typical peaches and cream complexion. You see, we have a famous Egyptian song, if you remember it, كل خد عليه خوخة. Remember? There is a peach here and a peach there, and the nose is also orange yellow in color, but the forehead, the bridge of the nose, and the skin over the upper lip all appear pale in color. There is periorbital puffiness with a pathetic look, and here the outer thirds of the eyebrows appear to be missing, particularly on the left side, and there is also swelling of the face, of the nose, and of the lips, and of the neck, and poorly managed scalp hair. Is it clear? Is it clear? Is the term peaches and cream complexion clear now? Huh?
Yeah.
Okay. Okay, now continuing the signs, if you measure the blood pressure in a patient with primary hypothyroidism, you will detect hypertension. Okay, here it's going to be diastolic. Okay, yani both systolic and diastolic blood pressures are elevated, unlike the hypertension we find in hyperthyroidism. It is exclusively systolic hypertension, like I'm going to mention. When we are going to revise hyperthyroidism. We find hypothermia. Hagga Zainab, actually, since she was an impending myxedema coma patient, her blood pressure was low. She was shocked. It was not high. And she was hypothermic. When I tried to measure her temperature, the thermometer didn't measure. It remained at 35 degrees, okay? Some patients with primary hypothyroidism present with heart failure. Hagga Zainab had severe bradycardia. Her pulse rate was 45 beats per minute. Okay, she had bilateral pericardial effusion, and she had pericardial effusion, and she had ascites as well. Actually, the reason for her admission to the ER was ascites for investigation. They didn't even bother to write impending myxedema coma, which would be more dangerous, yani, as a diagnosis, right? Myotonia, this is not very common, or actually it's rare. Muscle hypertrophy is also rare, but what is more common is proximal myopathy. Again, this is a sign, so you need to examine the muscle power of the flexors, extensors, abductors, and adductors of the shoulder and hip joints, okay? Slow relaxing reflexes. I'm going to show you a video on how it is elicited, okay? Remember the patient, the male patient we saw having hypothyroidism. Remember him? I don't remember that whoever presented this patient told us anything about the ankle jerk relaxation time. Please note that the ankle jerk relaxation time is a very important bedside test to detect the progression or the improvement of hypothyroidism. And I'm going to show you how it's done properly. Okay? Cold peripheries. Of course, Hagga Zainab, remember her? She didn't have only cold hands and feet, but all her body was cold like a piece of ice because she had hypothermia. Okay? And of course, carpal tunnel syndrome, we see that by eliciting the Tinel and Phelan signs I have shown you in the videos earlier. Edema, actually, Hagga Zainab was edematous all over, not only on the lower limbs, but also on the hands, on the whole body, the face and the neck were swollen. And she had pallor due to anemia. Okay. And of course, the classic picture of a slow, dry-haired, thick-skinned, deep-voiced patient with weight gain, cold intolerance, bradycardia, and constipation makes the diagnosis very easy. But actually, in real life, milder symptoms are more common, and so they are hard to distinguish from other causes of non-specific tiredness. So this is very important. So many cases are detected on biochemical screening, on doing thyroid function tests. Now, let me tell you about some diagnostic problems that may arise in certain age groups, like, for example, in children with primary hypothyroidism. They may not show the classic features that I have just told you about, but instead they may present with slow growth velocity or short stature. So in any short child, before investigating for growth hormone deficiency, you should fast test screen by doing the TSH level for primary hypothyroidism, okay? And they may have poor school performance. Remember, they have slow mental mentation, and they have a poor memory. So this is why they can't think properly. They won't be able to memorize the homework, or they won't be able to memorize what they have studied. So they often fail at school, not because they are stupid or because they have a low IQ. No, because the poor child has primary hypothyroidism, and he or she, they haven't been diagnosed as such, okay? Remember also that there may be arrest of pubertal development, particularly if the primary hypothyroidism occurs peripubertal. So a mother may bring her daughter or her son to the pediatrician saying, my daughter or my son haven't attained puberty yet. Before working up the child for delayed puberty, please check for the serum TSH level. They may have primary hypothyroidism, which is not diagnosed, okay? Again, in young women with primary hypothyroidism, they may not show the obvious signs that I have mentioned earlier, but you should exclude primary hypothyroidism in all patients, all young female patients presenting with oligomenorrhea or amenorrhea due to hyperprolactinemia, or hyperprolactinemia, menorrhagia, or infertility. Such patients usually present, they don't come to us endocrinologists, they usually present to the obstetrician or the gynecologist. So in these cases, the gynecologist, before working up for these different entities, they should do a simple serum TSH level. And again, in elderly, remember, the elderly patients, they always have atypical presentations of several diseases, among which is primary hypothyroidism. So they may show many clinical features that are difficult to differentiate from normal aging. Okay? Until here, any problems? Everything is, I think, very clear to you, right? Now, let me show you some pictures of patients. Here you see hypothyroid faces. This word faces, written with C-I-E-S. What does it mean? I mean, is it the same like face, written with C-E at the end, or does it signify something else? Who can tell me? Who can tell me? Let me show, let me see how many you are now. Sorry? Say again, please.
I think it means facial features.
Yes, very good. Yes, very good, Dr. Nadine. Facial features of hypothyroidism, yani hypothyroid faces, acromegalic faces, facial features of acromegaly, thalassemic faces, facial features of thalassemia, and so on. Okay, so here you notice these are 3 female patients. 2 of them are Caucasian, of the white race, and 1 of them is of the dark race, or the African race. Okay, طيب. This is an elderly lady, this is a middle-aged lady, and this is a young lady. Okay. Type. What do all of them share? They share the hypothyroid phases. Who would like to comment on this lady? Who would like to comment? Who would like to comment? Huh? Let me see if you understood the signs. Yalla. Who would like to comment on this lady? Don't waste time. Huh?
ماشي يا دكتور هقول هي
Oh, okay. In English, بس in English. يلا, tell me.
Puffiness of the face.
Yes.
Swollen nose.
Yes.
Periorbital edema.
Yes, particularly on the right side. It's very evident here, you see, as if she has bags of water below the lower eyelid. Yes, very good. What else?
Pale skin.
Yes, she is very pale. زي لون البفتة كده. Okay. She doesn't have peaches and cream complexion, although she is of the Caucasian race. Okay. Type. Okay. What else?
I think she has thin brittle hair.
Yes, and here in particular here, and she has temporal recession on the left side. You see, we can't see the right side because the picture is a bit shifted, the face I mean. So we can appreciate she has here temporal recession of the left side of the scalp hair. Okay, what about the eyebrows? Is there something wrong with her?
No, normal eyebrows.
Okay, يعني هنا you say no loss of outer thirds of the eyebrow. This is a good negative sign. Very good. طب, is there any goiter visible?
No visible goiter.
Very good. And she has, of course, a pathetic look. Huh? Sleepy eyes. Okay, very good. Thank you very much. Dr. Salma, right? Dr. Sama, I mean? Is it Dr. Okay. طب, who would like to comment on this second picture here? يلا. It's not that difficult. Dr. Sama has already commented on the first picture. Who would like to comment on the second picture? Shall I pick up somebody? Yani, don't waste time. Dr. Molisu, would you like to comment? Do you still have problems with your microphone? I can't hear you. I can see you have unmuted yourself, but no sound. No, never mind. Somebody else, Dr. Khulud, would you like to comment on the second picture? Dr. Khulud. Dr. Khulud. Come on, come on. Did you fall asleep or what? طيب, Dr. Hib. يلا. Can you still see my slide? يلا, the second picture. This lady.
Yes.
Yeah. Can you see the picture? I can't hear you. I can hear only background noise, but I can't hear your voice. Dr. Khulud. Dr. Khulud, can you hear me? It seems you have a problem with your microphone as well. Type, let me check somebody else, choose somebody else. Dr. Minnatullah Muhammad. Dr. Minnatullah Muhammad, would you like to comment, please? Dr. Minnatullah Muhammad, are you there?
She has yes, I'm here.
Doctor. Okay, yalla.
She's having an apathetic face.
Yes, a pathetic look, not face, look. Pathetic look.
Okay. Loss of hair in the distal third of her eyebrow.
Yes, very evident here on the left and on the right side. Very good. Okay, what else?
A marked bilateral periorbital edema.
Yes, very good. Very evident.
Swollen nose and puffy face.
Yes, and swollen lips as well. Yes. What else?
Brittle hair.
Yes, brittle, poorly managed hair. It appears as if she has just risen from sleep and she came to see you without combing her hair. And here you notice that she has what? This is what? Here and there.
Recession of hair.
Yes, bitemporal recession of the scalp hair. This is not normal for women. It would be a normal finding in a male, but not in a female patient. Okay? So what else? Does she have peaches and cream appearance?
No, it's not evident here.
But she is extremely pale as well. She has severe pallor.
I'm not sure if there's if this a thyroid swelling or not. It's not.
No, it's not. You cannot see. You cannot see clearly. Okay. Thank you very much. Thank you very much. Okay. The last patient. This one. The last picture. Who would like to comment? See, it's very easy. Who would like to comment? Dr. Heba. Dr. Heba, would you like to comment on the last patient?
Doctor.
Yes. Okay, go ahead.
Look, apathetic.
Yes, she has an apathetic look as well. Yes. What else?
Swollen lips.
Take
swollen
care,
face.
take care. The face is swollen. I agree with you. But regarding the nose and lips, remember, she is of an African race. Huh? Some African people, for them, it's normal to have a nose and lips that appear like that, right? So if the patient is in front of you, you ask her, did anything change in your nose and lips? If she tells you no, then this is how she has always looked like. خلاص? This is her normal appearance. If she tells you yes, then you ask her, what did you notice? How did they change? She will tell you, my nose became swollen, my lips became swollen. Only then are you justified to comment on them as being swollen. Okay? Is that clear? And the same applies for the scalp hair, because here you notice the scalp hair appears coarse and dry. Okay, it's poorly managed, but it's normal for many African people to have coarse and thick hair like that. Okay, so you ask her, if the patient is in front of you, you ask her, did your scalp hair change in any way? If she tells you no, so this is her normal aspect. If she tells you yes, then you ask her, how did it change? She will tell you it became coarse, dry, poorly managed. So only then are you justified to comment. Is it clear? Go on, Dr. Hiba. Continue. What else can you tell me about this patient? What else? Anything wrong with the eyebrows?
No.
Type here you say what? That's a good negative sign. No loss of the outer thirds of the eyebrows, right? Type, can you actually see peaches and cream complexion in this dark-skinned lady?
Some pallor بس مش هيبان.
She appears a bit pale, right? But you cannot appreciate peaches and cream complexion like in the Caucasian race because of the dark melanin pigment. So actually here in Egypt and in many countries of the Middle East and of course in African countries as well, you will not be able to detect the hypercarotenemia that I showed you earlier, but you will be able to appreciate the pallor, right? Okay, thank you very much. Type. These are two other patients, a young lady and an elderly gentleman. Who would like to comment? يلا. يلا. Shall I specify somebody? Dr. Dalia Izzat, would you like to comment on this young lady on the left side? Dr. Dalia Izzat.
دكتور للأسف السكرين مش واضحة عندي أصلا، السلايدز مش معمولة سلايد شو عندي.
مش معمولة عندك سلايد شو؟ طب استني
لا
بس. طب now إيه؟ Is it slide show now؟
لا عندي مش موجودة خالص، فأنا قلت يمكن المشكلة من عندي أنا، فقلت أسمع بس عشان ما
طب
أعطلش
لا طب يا بنتي، طب ما قلتيش ليه؟ Why didn't you speak up؟ يعني I'm showing you pictures. You have to speak up. Let me share my slides again. Hopefully this time you are going to be able to see. يعني has this been going on برضه since the very first presentation؟ ها؟
لا الفيرست برزنتيشن كده كده ظهرت.
طب اوكي طيب يلا. Can you see now? Is it slideshow? Is it slideshow?
يا دكتور.
اوكي يلا go on.
بالنسبة للميل في
لا مش الميل. لا I want you to comment on the lady, on the female patient. This one. يلا comment.
ممكن من أول الهير بريتل والشورت شوية
لا هو مش شورت، هي كأنها she has like a chignon، يعني she has put her hair all to the back. But here you can see this here, the hair here appears what? How does it appear like?
هو بريتل شوية.
Brittle and it appears as if it's poorly managed يعني كأنه منكوش يعني شوي. Okay, what else? What about the eyebrows?
No loss of
yes, very good. يعني here they are intact, you see? You can trace them from the medial to the lateral. There is no loss of outer thirds of the eyebrows. Okay, what about the eyes? Anything wrong with them?
Apathetic look.
Yes, a pathetic look. Very good. And there is mild periorbital puffiness as well, particularly on the right side. Okay. What else?
فيش جوتر والنوز والماوس مش هنقدر نحدد عليهم غير لما نشوف حاجة قبليها.
أيوة. طيب the nose and mouth, at least the lips, they appear a bit swollen, but the nose, you can't tell for sure. You have to see the picture of the patient before becoming sick. Okay. طيب, you say she has a goiter. Does she have a goiter? Actually, you can't
Very
just
mild.
يعني you have to طبعا you have to see the patient in front of you and ask her to swallow to see if this apparent swelling moves up and down on deglutition or not. طيب, does she have a peaches and cream complexion? What do you think?
I don't see.
لا, you see it's mild, a bit mild. You see the cheeks appear as if she has applied rouge à joues. Huh? Makeup يعني, huh?
Yes.
You see, they appear a bit
Okay.
red in color, and the rest of the face appears pale in color. So she has mild peaches and cream complexion. طب, what about this neck? Does this neck appear normal? See, what is this?
Turner.
أيوة, this is webbing of the neck. Although it's mild, يعني cases usually have more severe webbing. This is webbing of the neck. Webbing of the neck is found in Turner syndrome. But what is the association of Turner syndrome and hypothyroidism? Is there an association? Yes or no?
I don't know.
Very good. Thank you for being honest. Type. I will tell you. Yes, studies have shown, epidemiological studies have shown that there is an increased instance of occurrence of primary hypothyroidism in cases of Turner's syndrome. Okay, thank you very much, Dr. Delia. Somebody else would like to comment on this gentleman? Yalla, who would like to comment? Yalla, who would like to comment? Dr. Khulud, would you like to try your microphone again, if you're still with us? Dr. Khulud, are you still with us? Can you hear me? Type Dr. Minna Aboul-Qasim. Would you like to try? Dr. Minna Aboul-Qasim? Can you hear me? It seems you're not there. Dr. Mwalisu, would you like to try? Can you still see this? Yes, I can. Yes, you are. Yes, go on. Yeah, comment on this gentleman.
Okay, yeah, so there's puffiness, there's periorbital puffing.
Yes, it's very mild, but it's there. Very good. Yes, what else?
The hair is brittle, looks brittle.
Yes, the hair looks brittle and it's dry. It seems to stand on end
dry.
like that. Yeah, but you notice the patient has hair loss as well, right? But remember, he's a male. He's a male. So ask the patient if the patient is in front of you. Male patients usually, not usually, some male patients develop baldness, right? When they age.
Yeah.
So it's perfectly normal. So you ask the patient, is your scalp hair normal like that? If he tells you yes, okay, so he has been bald ever since. If he tells you no, then you are perfectly justified to comment on loss of scalp hair. Okay?
Okay. Okay.
Okay, what about the eyebrows?
Okay. The eyebrows, there seem to be a bit of loss, but
yes,
it doesn't look like to be
compared to this patient, you see, actually the hair of the eyebrows appears to be thinned out. But if you look closely, if you trace the eyebrow from medial to lateral, it will stop here. So this part doesn't have any hair. And even here, it's even more obvious. You see, from medial to lateral, the hair stops here. Okay? So there seems to be loss of outer thirds of the eyebrows, unlike this patient, if you compare. Okay? Type, what else?
Okay. And there also seems to be like peaches and cream appearance. The cheeks appear a bit.
Yes. They appear more pink, orange pink in color than this lady here.
Yes.
Okay.
Yes.
What else?
Other than that, the lips don't look swollen, but they look a bit pursed.
Yes. Actually, you can't comment really very nicely on the nose and lips because it's not very evident. You have to have a picture of the same patient before being hypothyroid in order to be able to compare. And what about the neck? Is there any goiter or is there any swelling?
I can't really tell from the picture. There seems to be a sort of at the level of the sternum, not really at the level of the neck. There seems to be some swelling, but I can't be sure.
No, actually, if you are talking about this here and that, this is the sternoclavicular joint here. It's here.
Yes,
if you can see my picture.
Yes.
The sternoclavicular joint is swollen. Why is it swollen? Because this is an elderly gentleman. This is something called Tights syndrome. This is osteoarthritis of the sternoclavicular joint. When it's acute, I mean, when it's active, I mean, it appears swollen, more swollen than that, and red in color. But here it appears to be chronic, as if he has been having this since several months. Yeah. So this is what we call Tights syndrome. Okay, remember that.
Okay.
Thank you very much, Dr. Molly. So very good, excellent. Now look at this is a young gentleman on the left-hand side, and this is a middle-aged lady on the right-hand side. Who is there any difference, or are there any similarities between both of them? Both of them have hypothyroid faces. Okay, I will tell you, both of them have a swollen face. Here you can see the neck properly, and here even you can see the neck because the patient is wearing a high collar neck or a neck yarn. A neck collar. So this means that whenever you have to examine a patient who is wearing a neck collar, or a high cowl, or a turtleneck, that is, or if the patient is wearing a veil like me, and you want to examine the neck for the trachea, the thyroid, the lymph nodes, the carotids, and the internal jugular venous pressure, you ask the patient kindly to uncover her neck. Alas, this is a very important tip for you. And what else? So this gentleman appears to have a very evident peaches and cream complexion, right? You see, the skin of the forehead appears to be very pale yellow in color, and the cheeks and the nose, they have this orange yellow color in the butterfly region. This is a typical peaches and cream complexion, while this lady, maybe she shows some pallor, but unlike the previous patients. Okay, coming to this gentleman, he has an evidently swollen nose and evidently swollen lips, upper and lower lips, right? Very evident. The whole face is swollen in both patients. And this patient, this lady, she has a swollen nose, particularly near the bridge, the bridge of the nasal bridge here, this area there. Okay, and she has swollen lips, more so the lower lip. All right, both of them have apathetic looks, but this young gentleman looks more apathetic than this lady, right? Both of them have periorbital puffiness, but this lady has more severe periorbital puffiness, particularly on the left side. It appears as if there are bags of water above the upper eyelid and below the lower eyelid on the left eye. Okay? What about the eyebrows? This gentleman this is typical loss of outer thirds of the eyebrows, but more so on the left side, here, more than the right side. What about this lady? Look at her eyebrows. How do they look like? They appear as if the hair of the eyebrows, it's intact, all through. You can trace the eyebrows till the lateral ends, but, so there is no loss of outer thirds, but the eyebrow hair appears to be thinned out. Some people are normally like that. So if the patient is in front of you, you just ask her, did your eyebrows change in any way? If she tells you no, then she has been like that ever since. If she tells you yes, you ask her the next question. How did they change? She will notice, being a female, she will notice the hair of my eyebrows have become less thick. Okay, is it clear? Coming to the scalp hair of both patients. The male patient, he has evident temporal recession on the right side and more so on the left side. Okay, so this is a completely normal finding in male, so you don't actually comment on it. But here I would comment on the left side. Why? Because it's more, there is more temporal recession on the left side than compared to the right side. So this means that there is loss of hair here more than there. Okay. Regarding the rest of his scalp hair, it appears to be dry, brittle, and poorly managed, although he is a male. Probably he wouldn't complain of such things, unlike the lady. The lady actually has nice, thin hair that appears, it has a luster still, but it appears poorly managed, as if she was standing in front of the fan and the hair was tossed around by the air coming from the fan. It's poorly managed. Okay, but it's still not dry, still not brittle, and still not coarse, unlike this patient. Is it clear? Are the differences and the similarities clear? Okay. Now here, this is a severely hypothyroid lady. She's a Caucasian lady. She's a lady, right? She's not a man, but in spite of that, she has baldness. You see? She has loss of scalp hair. Evident, very evident. Haga Zainab, the one I told you about, she looked more or less like this. But in addition, she had a veil on top of her scalp. And look at her face. It's extremely pale with peaches and cream complexion over the cheeks. And she has a swollen nose, swollen lips, particularly the lower lip. We can't visualize the neck. She has severe periorbital puffiness, almost closing her eyes, particularly the left side. And she has loss of the outer thirds of the eyebrows, not if not the whole eyebrows. Haga Zainab looked like this lady. Okay? Alas, is it clear? Now, these pictures I like a lot because they compare, this is the patient, the same patient, when she was hypothyroid in panel A and in panel B, on panel B, when she was healthy. So here you can perfectly see the differences before and after treatment. Here, obviously, there is facial swelling and neck swelling as well. You can see there is effacement of the folds of aging. They are not visible, although there is no goiter. She has a swollen nose if you compare both pictures together, and swollen lips, particularly the lower lip, okay, and the upper lip. And here, the pitfall in this picture is what? The patient is wearing eyeglasses. So in order to be able to examine the eyebrows and the eyes and the look, you need to ask the patient to remove the eyeglasses, okay? But in spite of that, here, since she is raising her eyebrows on panel A, you can see that there is loss of the outer thirds of the eyebrow on the right side, okay? But the left side is intact. And she has a definite apathetic look with periorbital puffiness. Here you see the eyes are lively, they're even smiling. But here we can't appreciate the eyebrows because they are covered by the frame of the eyeglasses. And here you notice the scalp hair appears very dry and brittle and poorly managed. But here she has a nice comb. Okay, is that clear? But here you notice that the patient actually she has the skin color appears bronze in color, bronze. Okay, so we can't really say she has a peaches and cream complexion compared to this nice pink complexion. Is it clear? This is another picture of a patient showing the patient's picture having hypothyroidism. Although here in this picture, it might be a bit confusing with acromegalic features, but actually if you pay close attention, you will find that she has periorbital puffiness, which is not the case in acromegaly, and the eyebrows are the same, okay? And the nose is a bit swollen, the lips, particularly the lower lip, is a bit swollen. She has facial swelling as well, together with neck swelling, because here you see the fold of aging is effaced. You see, it's not visible in this picture. but she has pallor. She doesn't have peaches and cream complexion. And if you compare the scalp hair, here it appears coarser and more brittle and less well managed than here. Okay, is that clear? Can you see the difference? Okay, now this is a patient with myxedema coma. As I mentioned earlier, myxedema coma is one of the endocrine emergencies. يعني الحاجة زينب, if her daughter would have left her at home for 2 or more 3 days, she would have come looking like that. You notice this is a lady, huh? The scalp hair is almost all totally gone, loss of scalp hair, no eyebrows whatsoever. You see, she has the يعني she's not asleep, she's in a coma actually. She's comatose. And she has severe periorbital puffiness, particularly on the right side, with bags of water on the upper and lower eyelids. The nose is very much swollen, so are the lips. She has macroglossia, or not macroglossia, she has a swollen tongue as well. And she is admitted to an ICU. How can we tell? Because there is an endotracheal tube in place, the orange part, and there is a nasogastric tube in place as well, the one with the that is graded. Okay, so this is myxedema coma. Okay, now coming to the pattern of loss of hair, it may occur on the temporal side, okay, only like here, and like the pictures I've shown you earlier, or it may be like that. Here you can see like at Haga Zainab also, there is extensive loss of scalp hair, and you notice the scalp hair appears brittle and dry, and it's as if like a leaf, you know, like the sponge that we use here in Egypt to take a bath, to bathe ourselves. It's مكتكت كده, huh? As if it's full of knots, yeah. Huh? So the patient will tell you, of course, I cannot comb my hair properly. It's poorly managed. Okay, or it can take this appearance. This is actually extensive alopecia areata. This is of autoimmune nature. You can notice this with the autoimmune causes of hypothyroidism, of primary hypothyroidism, like the autoimmune atrophic thyroiditis or the Hashimoto's thyroiditis. Okay, there are patches of scalp totally devoid of hair. It can be localized, or it can be alopecia areata totalis or universalis. Remember, we have, you can see a lot of patients in the street having the alopecia areata universalis. One famous actor, the one who appeared في مسرحية شاهد ما شافش حاجة في المشهد بتاع المحكمة. He was very tall and very big, he looks very frightening, and he doesn't have any hair whatsoever, not on the scalp, not on the eyebrows, not on the eyelashes, not even on the body. This is an autoimmune type of alopecia areata called alopecia areata universalis. Okay, so always remember that. And this is vitiligo. These are patches of depigmentation. It's also an autoimmune disease where there are antibodies against melanocytes in the skin. It may be localized, like here on the back, and here on the knees. This is the normal skin color. Okay, and these are the patches of vitiligo, or it may be generalized like Michael Jackson. Remember Michael Jackson? When he was young, singing with his brothers and sisters in Jackson 5, he was black in color because he was of African American origin, right? But later on, when he became an adult, all of a sudden he turned white. Some people say he used to paint his body white, but it turns out he developed generalized vitiligo. Okay. Now this is carotenemia, the one that I told you about earlier. This is a normal hand, palm. You see, normal, pink in color. Look at your own palm, and the arrow is pointing at the palm of a patient with hypercarotenemia that appears orange yellow in color. This is another palm. Actually, when I was an assistant lecturer a long time ago, I used to attend the endocrinology outpatient clinics with the residents, and there came this young female 25-year-old patient. She came complaining of nothing but orange discoloration of the palms and soles of her feet. at that time, I was astonished. I didn't know about this hypercarotenemia, not yet, at least. I was still studying for my PhD, my doctor degree. So I was really astonished. What is the cause? I thought because she came from the countryside. In the countryside, it's very common that they use henna. You know, henna is like a herb that they use to color their palms and soles, either dark brown in color if they use the black henna, or red in color if they use the red henna, right? So I asked her, did you use henna on your hands and feet? She tells me, no. Did you use henna on your scalp? On your hair, I mean, scalp hair? Because maybe she used it to dye her scalp hair without using any gloves. So this would obviously dye her hands. But what about her soles? She told me no. Type, do you eat a lot of carrots? No. Type, do you drink a lot of carrot juice? I don't like it. So I told the residents, okay, so let's admit this case, this patient for further workup. So we did a lot of blood tests on her. We discovered she had, if I remember correctly, hypochromic microcytic anemia. And when we asked retrogradely about the menstrual history, she had menorrhagia. So this figures why she had iron deficiency. And she turns out to have, the TSH was very high. It was 100. And the free T4 and the free T3 were very low. So it turns out she had primary hypothyroidism, which caused this carotenemia. Okay? Okay. And this is the dry, scaly skin. This is how it looks like. This is the skin of a Caucasian person, patient, I mean, with primary hypothyroidism. And you know, the skin is wrinkled. It has some scales. It looks dry. And this is the typical, this is how the skin of Al-Hagga Zainab that I told you about earlier looked like. She had like fish scales on her skin. It was scaly, dry, rough, like sandpaper, and her skin was this color, had this color. So obviously we couldn't detect any peaches and cream complexion on her face. Okay? Now, regarding congenital hypothyroidism, this is how a neonate with congenital hypothyroidism would look like. He or she would have a swollen face with a swollen nose, swollen lips, and a swollen tongue protruding from the mouth, and a depressed nasal bridge, apathetic look, and periorbital puffiness. And here you notice that the eyebrows are, the hair of the eyebrows is very faint and very thin, and the scalp hair appears to be Bordeaux, coarse and dry and poorly managed. And here, of course, there is this prominent pot belly, Kirsch al-Matin, yani, with a prominent persistent umbilical hernia, because neonates usually they have umbilical hernia, but it tends to disappear with time. But in neonates or babies with congenital hypothyroidism, they tend to have this persistent umbilical hernia. And of course, if the mother is very clever and she will notice that her baby has constipation, because normally a baby would pass stools after every breastfeed or even after every bottle feed. Okay, but not in that case. She will bring her son or her daughter to the pediatrician saying that my child has constipation. Okay, my baby has constipation. And she will also notice, particularly if she has had children before, that the voice, the cry of her baby appears to be hoarse and deep. Okay, this is a further important sign. Okay, any problems so far? Any problems so far? Are you tired? Huh? Sorry, what did you say, Dr. Moliso? Any problems? Anything that is not clear so far?
So far, it's clear.
Okay, but you're tired, right?
Yeah.
Yeah, I am tired too.
I'm just for the benefit of the others, maybe if we could continue.
I'm much older than you, so if you are tired like that, I am tired like that.
Yeah, I understand.
Okay, so I can stop here if you like. يعني I don't have any problems.
Yes, that's
But for
reasonable.
your,
That's
yeah,
reasonable.
so I suggest if you like to have another session before your exam, just let me know. But on Thursday and Friday, I'm not available this week. Your exam is next Sunday. So tell me and we have tomorrow and we have Wednesday. So tell me what would be suitable for you if you like. If you don't like, then we can postpone this the rest of the revision till the end of the module, yani towards before the final exam. What do you prefer? Tell me, what is it you prefer?
If others agree, I think Wednesday.
Similar
time Wednesday.
You tell me, but you tell me. You Dr. Moliso suggested Wednesday of this week, 8 o'clock in the evening. What about the rest of you? Would that be suitable for you? Huh?
Wednesday is fine, doctor. Wednesday is fine.
طيب, what about Dr. Khulud, Dr. Nadine, Dr. Minnatullah, Dr. Minna Aboul-Qasim, Dr. Hiba, and Dr. Dalia? What do you think?
تمام doctor.
Sorry?
تمام يا دكتور مناسب.
Okay, so please put an announcement in English on the WhatsApp group, please, that there will be another continuation of the revision session this Wednesday, inshallah, at 8 p.m. in the evening. Okay? All right?
Okay.
Okay. In the meantime, please try and read what I have revised with you. I think there is nothing new, actually, Yani. This is just a revision. But try and read if there is something that is not clear. And in the meantime, also try and show if you can log into the faculty portal. Because I have placed many of the videos I have shown you on the portal. I have also placed a very nice textbook, Greenspan textbook of endocrinology. You can consult that if you have any problems. I have put some the PowerPoint presentations that were sent to me by Professor Temer Shoubini and the different colleagues. Okay, except the one that was presented yesterday. I haven't received it yet. Okay, so please kindly ask Dr. I don't remember who presented. Dr. Selma, I think. Was it Dr. Selma?
Dr. Yasmin.
Dr. Yasmin, yes, please kindly tell her to add the. I was told, Dr. Hana Nagar told me, she showed me actually, she had the pictures of the MRI and the CT showing the fibrous dysplasia, osteodysplasia, to put these in her presentation and to put the perimetry, the findings of the perimetry in her presentation as well before sending it to me, okay? So that I can upload it on Moodle for you. So from today until Wednesday, please tell me if you can access the faculty portal or not, so that I can contact Engineer Ahmed Barakat at the e-learning unit again. Okay? Can you please fill out the survey for me? I know you are all tired, but can you do you still see the link? Yes, you have the link. I will show you I will share with you the questions. They are actually very simple. Where is it? I can see it. Here. You see, till now nobody has responded. Can you see my slides, my screen?
Yes.
The questions are actually very simple. They take only like 1 or 2 minutes to answer. There are 8 students now with me, so I expect to find 8 responses, please. I will read out the questions for you. The timing of the session was appropriate. The duration of the session was appropriate. The session was well organized. The content of the session was very clear. The instructor was well prepared. There was adequate time for asking questions. What did you like most about today's session? What would you like to change in this session? So please respond. Kindly respond. By responding to this survey, you are going to help me in a great way to improve my further or my future online teaching. Okay? Did all of you Could all of you access the link in the chat of Microsoft Teams?
Yeah, for me, yes.
Yes.
For
Okay.
me, yes.
Okay, time. Okay. Yeah. It doesn't take that much time to respond. Till now, no responses, as you can see. All you need to tick is actually, all you need to do is tick the answers, the correct answer. You have only two open-ended questions. I have a response by now. Okay. All right. Okay, it was very informing. Okay, thank you. Okay, thank you. And those of you who answered the survey, please keep...
Doctor, please send the link.
Sorry? Dr. Delia?
The link of survey.
The link, it's in the chat. Can you see the chat of the Microsoft Teams? I will put it again. 1 second. I will put it again. Can you see the chat? Can you open the chat of Microsoft Teams? Huh?
تمام يا دكتور.
Can you, did you see it?
Yes.
Okay, I put it again. I just shared it again. Okay. Does anybody else have a problem accessing the survey? Okay. For those of you who answered the survey, please keep staying with us, because you know, all of you who answered the survey know what you personally wrote. But I think it's always nice to know what your colleagues think as well. So I'm going to read out the responses of the survey to you. After all the participating students have answered. Until now, I have only 2 responses. The rest of you, what about the rest of you? Dr. Moliso? Sorry?
The first question is in Arabic. The first question is in Arabic, so...
No, it's not in Arabic. All the questions are in English. The first question says the timing of the session was appropriate.
Before that. Before
that, there is written in English, like that, exactly like I've shown you, like my screen shows you. Evaluation of the first revision session for postgraduate students. Please take a few minutes to submit feedback regarding. There is no Arabic at all. It's all in English. Everything is in English. Okay? Okay, Dr. Moliso? Okay. Yalla, I have 3 responses so far. So the rest of you, would you kindly hurry up? 4 more remaining students. Doesn't take that much time to answer, because all of us are very tired, and we certainly need to go take some rest. So please hurry up if you intend to answer the survey. Did anybody have any problems accessing the survey so far? Dr. Delia, could you see it? Dr. Hiba, Dr. Minatullah, Dr. Nadine, Dr. Sama, Dr. Khulud. Could you open the link?
Yes, doctor, I have opened it and filled it.
Why are you taking so much time to answer? Now 4 responses, 3 more students remaining. It doesn't take that much time. What are you doing, Yan? It's all right. Okay. Yal. The 3 remaining students, please kindly respond to the survey, please. 5. Okay, 2 more to go. Yalla. Yes.
I'm trying, but
what?
It's not picking.
What is not picking? You cannot open it? You cannot open?
I've opened. I've opened. I see the first question is timing of the session was appropriate. The duration of the session was well organized. I can see all the questions.
Sorry, what is the problem? You cannot click on the answer?
Yeah, on the circles. Yeah, when I click, it's not.
Maybe you should try and open it again. Maybe you have a problem with your internet connection. Maybe try and open the link again. Close it and open it again. Okay, now I have 6 responses, so it appears that you are the one remaining. So until you are able to answer, I will start reading out the responses to you. The timing of the session was appropriate. 66.7% strongly agree. 33.3% agree. The duration of the session was appropriate. 66.7% agree. 16.7%, this is one, strongly agree, and another one is neutral. No opinion there. The session was well organized. 83.3% strongly agree. 16.7% agree. The content of the session was very clear. 66.7% strongly agree. 33.3% agree. The instructor was well prepared. 100%, all of you strongly agree. There was adequate time for asking questions. All of you strongly agree. What did you like most about today's session? It was very informing. The photos and the clinical signs, the interaction. The doctor kindly explained everything with the very easy way. Yeah, that's nice to hear. The photos are clarifying each of the signs, very informative. Thank you very much. Clinical scenarios mentioned helped a lot. What would you like to change in this session? Nothing to add. Case-based scenarios for proper approach and management. Yeah, maybe I would do that before in the session before your final exam. I will try to do that. Addition of some questions to help us in our exam, nothing. Less duration of the session. It was very long. Yes, I think so too, but you see, there is a lot to cover. If I want to revise the whole of the endocrine topics, all of the endocrine topics that we have discussed so far, of course, it would be very long because there is a lot to cover, particularly in the imaging. Yeah. Okay. And particularly, Boudou, that you take a lot of time when I ask a question, you take a lot of time to answer it. This loses a lot of time. Okay. So I'm sorry I took so much of your time, but I sincerely hope it was very beneficial to you and very fruitful. And I hope it will help you in your upcoming midterm exam and in the final exam as well. All right. Any comments, any suggestions, any questions before we leave?
يا دكتور شكرا جدا لحضرتك، المراجعة كانت جميلة جدا.
Thank you very much for your positive comment, Dr. Sama. I'm really very glad that it was very fruitful and very beneficial. So I wish you the best of luck. I will see you. I will see more of you, hopefully, on Wednesday, inshallah. But Dr. Sama, if you would kindly remind me to make the Microsoft Teams link and send it to you, okay? So that you can send to your colleagues, okay?
تمام يا دكتور.
All right. Thank you very much. Okay. Thank you very much. I wish you a very pleasant evening or good night with happy, sweet dreams. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam.